30 seconds to go. Good afternoon.
Good afternoon.
Welcome to Senate Finance. Today is Tuesday, February 14th, 2023. Happy Valentine's Day. In case you haven't heard it, you now have. Happy Valentine's Day. From Senate Finance, we have 9 bills that we're going to be considering today. I'm going to read the order in just a second. Let me say to our visitors, you will see members in and out of the room throughout the hearing. They're presenting bills in other hearings, and so it's not a lack of respect for you or your subject matter. It just means that they have a bill they've worked on and are presenting before one of our other fantastic standing committees. Speaking of fantastic standing committees, we're going to start our bill hearing today. And I'll read all of the bills and then we'll turn it over to the Chair of Budget and Tax. We're going to start with Senate Bill 362, then go to Senate Bill 237, Senate Bill 255, Senate Bill 370, Senate Bill 349, Senate Bill 399, Senate Bill 213, Senate Bill 215, and Senate Bill 216. The first bill for your consideration, colleagues, is Senate Bill 362. Chair Gazon, Certified Community Behavioral Health Clinics. You have your panel. Mr. Chairman, you have the floor. Good afternoon.
Thank you. We have to be very kind to one another as we have bills in each other's committees. This committee clearly understands, because they hear it a lot. We're all scrambling, right? We for years in the mental health field, you couldn't talk about mental health issues, and now everyone realizes how significant it is. And COVID crisis made it even worse. And now we know we have a serious responsibility to find solutions for the population, because it hits every family in lots of ways. This bill, I believe, is a critical one in the component parts to make this happen, to treat this issue with the respect that it deserves to be treated with. It's about centers, clinics that could be throughout the state. And it's based on a model that was used for the federally qualified health centers. In 23 states right now, these clinics are operational. These centers are operational, and there are 450 of them across the United States. We have done sort of it's not exactly a demonstration project by the lingo, but we have 5 of them operating already in this state. And I think they're doing a fabulous job. You're going to hear about what they do. If you open the bill to the second page, you see that it requires these centers to do 11 things. And I'm just going to say a couple things real quickly. Outpatient mental health and substance services, obviously. 24-hour mobile crisis response and hotline services. We just passed the 988 bill the other day. This fits right into that. I want to mention also that the beauty of this is that everyone is welcome to these clinics, whether you have insurance, whether you don't, no matter what your payment or non-payment is, you're open to this. I'm going to let the others talk about a lot of this, but what I want to say on the 2 points in here, if you look at number 5 and 6, it says that these clinics also provide primary care screening and monitoring of key indicators of health risks and targeted case management. The reason why this is important is when someone comes in with mental health issues, they may also have other health issues, and being able to recognize all of this, manage the case, be able to handle the whole person is really the future of how we should be doing this. It's the way that we keep people out of emergency rooms. It's the way that we can actually save money by using less expensive means and getting to people earlier. And that's really what I think is the beauty of this. You will see a fiscal note that is lists some initial dollars to be expended. But then in the back, you'll see a higher number, significant number. And the question is that exactly the way it's going to come down? And let me make one point about that. The department has the ability to bring on these clinics at its own discretion and own time frame. So it's not like that's the number there is if everything happened all at once. And I don't think that's the case. I don't think that's the way it would happen. That's one. And two, as you know, we all struggle with the fact that we'd like to have information about cost savings. And a lot of times that's not reflected in the fiscal notes. And I think clearly in this case, and I think you're going to hear a direct testimony about the ones that are active in our communities right now, that they are saving money. They are saving Medicaid dollars, it's saving ER dollars. This has the ability to do so much to help people and do it in the kind of responsible way that I think is necessary. As you can imagine, sharing budget and tax, I would not have brought this forward if I didn't think there was a way to move forward with this, move forward with it now, and do it in a responsible way that's going to make a difference in a lot of people's lives. Thank you, Madam Chair.
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland. And we thank Senator Gazzoni for being such a strong champion of behavioral health and for laying out the challenges we face in Maryland. The cracks in our system continue because we haven't focused on services that keep people out of crisis. And the question is now how to fill those cracks in a way that checks off all the boxes, and CCBHCs is that solution. So our state faces problems like access to community behavioral health services for kids. CCBHCs must serve kids. Overutilization of emergency departments and inpatient care for those with behavioral health needs. Our written testimony lists the impressive results other states have gotten in addressing this problem through CCBHC. People in crisis, CCBHCs are required to provide 24/7 crisis intervention. Opioid overdose deaths, CCBHCs are required to provide substance use disorder treatment, and the data show significant increased access to that treatment in CCBHC states. Workforce challenges, CCBHCs participating in the demonstration program hired an average of 117 new staff positions each, including adult and child psychiatrists. I'd like to talk about the fiscal note for just a moment, since we think the estimates are way out of line with what we've seen in other states. Many of the CCBHC required services are already covered by Medicaid. This model would not require the level of spend in the fiscal note, but would require connection among those services that is lacking now. The fiscal note does not include the cost offset we've seen in other states. In fact, a recent evaluation of New York, which was one of the original states, showed that their CCBHC program became budget neutral in 3 years. The state is in the driver's seat, as the sponsor said. It determines the number of CCBHCs and approves their individual budgets. CCBHCs must then live within those means. We're now in a surplus situation. We have opioid restitution fund money coming in. New York, New Jersey, Rhode Island, Pennsylvania, West Virginia, and our neck of the woods have all decided to invest in this, and we'll see fit to do so as well. Thank you.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland, here in strong support of Senate Bill 362, which is priority legislation this year for the Maryland Behavioral Health Coalition. The fact is, we have never been in more dire need of the types of services that these programs provide, especially those for youth. I mean, the stats that I could list are endless, but I'll just name one. In new CDC data that came out just yesterday, 60% of teen girls reported feelings of persistent sadness or hopelessness, and a full 30%, or almost 1 in 3, said they have seriously considered attempting suicide. To quote the director of the CDC's Youth Division, in nearly 30 years of collecting similar data, we've never seen this kind of devastating, consistent findings. There is no question young people are telling us they are in crisis. The data really call on us to act. And CCBHCs can help. Outcomes from other states that are operating these programs and from those operating in Maryland, as you'll hear from in a little bit, are beyond impressive. The establishment of a state CCBHC program pursuant to this bill is critical to maintain the momentum of these programs, to build on their success, and to provide Marylanders with the community behavioral health services that they desperately need. And in closing, just to kind of echo Ms. Doyle's comments about the fiscal note, we have a real tendency in this country and in this state to resist paying for the prevention and early intervention treatments that can keep people out of medical emergencies and keep people out of behavioral health crises. Less than 6.5% of total healthcare spending goes to primary care. Less than 3.5% goes to behavioral health care, with less than 1% of total healthcare spending going to substance use treatment. And that ends up absolutely killing us on the back end, both literally and figuratively, in ED visits, in serious chronic conditions, in high cost procedures, et cetera. And so we really have to break this cycle. We really have to get upstream and prevent more serious and costly sickness and illness. And I know you all are tasked and need to consider whether we can afford to do this, but I think the real question is whether we can afford not to. And so I urge your support for Senate Bill 362, and thank you for the opportunity.
Good afternoon, everyone. My name is Jeff Richardson. I'm the Vice President and Chief Operating Officer for Community Services for Shepherd Pratt. And we are actually in our third round of grant-funded CCBHC funding in Baltimore County and in Baltimore City. And as you've heard everyone say so far, we have seen remarkable clinical outcomes. We've seen widened access for people. We are providing care coordination that's reducing the overall Medicaid costs for those individuals in the program because we're coordinating medical care for these folks. The biggest challenge that we have is the span of these grants is not forever. This is a couple of years. So we start these programs and this will end. And any momentum that we've had across the state will stop. The important things that we're seeing across all of our programs, and you've heard everyone mention this today, we are serving the demand for outpatient and treatment services across Maryland is growing. Access is shrinking. And we need to do everything we can to ensure that the right level of care is available for folks. Not everyone needs to be in an ED or an ER. You guys have all heard about the boarding and ED emergency room issues. These programs require urgent walk-in access to all of these services and provide them on the spot. One of the other things that's really critical about these programs is it also allows us to do the engagement both into hospital systems, criminal justice, and one of the things not mentioned is the growth in veteran services. We are treating a number of veterans through this program, which would have otherwise not had access to care. The other extremely important thing to present with this is that we are, as Lori mentioned, in a workforce crisis. We need to find a way to not reduce, but expand access and recruit and retain people to do this work successfully into the future. Thank you.
Thank you. Questions for the sponsor panel? Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, Mr. Chairman, for this bill. Obviously, the need in this space is really great. So the Certified Community Behavioral Health Clinics, this is for the expansion of them. And as far as, gentleman from Shepherd Pratt, you said you have these clinics now. So how many do we have like in the state? And what's the vision to have them spread out throughout the state of Maryland? And if you could go with that, please.
Well, thanks for your question. First, start with what other states have done, which is they've started progressively, meaning day one, they weren't everywhere in all places and all locations. But the goal would be to have them in every community that needs access to behavioral health services. But what's happened in other states as they've rolled this out, they've identified either folks who've done what we've done already, and the other 5 providers in the state have done this with these grants to get the ball rolling. The second piece is identifying providers in these jurisdictions that have the set of services that could be built on to provide that access of care. So as Senator Gazzoni mentioned, there's a range of services, outpatient treatment services, case management, addiction services, urgent walk-in capacity, all that have to be built into this model, along with partnerships with providers and criminal justice and the veterans systems throughout this whatever jurisdiction. So these may look very different in different jurisdictions across the state.
Yeah, so now there's there's a patchwork of services available throughout the state, whether it's health departments with clinics and stuff like that. So these will be new standalone, fully staffed clinics throughout the state. Is that?
So the good thing is, oh, go ahead, Lori.
I was just going to add to what you said. The difference that this bill makes is that would require the department to go for a state plan amendment, to actually amend their state plan to include this model as part of the service delivery. So rather than organizations like Jeff's having to rely on the federal grants that may dry up or they may not get extended, this would implement the model in the state of Maryland.
Yeah, okay, thank you for that. And so I'm going through the bill, it includes services to veterans. So as a veteran myself, there's a big need in that space. And unfortunately, it seemed like our federal Department of Veterans Affairs is not really able to keep up with that. So would you work with the state and the federal Veterans Affairs for reimbursement? And that's another payment source for as you treat veterans?
Absolutely. We're doing that now. And again, it's provided, we have been able to hire someone specifically dedicated to connecting with veterans who walk into our other veteran services and connecting with the VA directly.
And so with the VA medical records, and you'll have a seamless from that veteran's time in service to now, or is it be?
We would love to have that if we had the long-term funding to be able to invest in that.
Okay.
Again, two-year grants don't quite offer that level of depth.
Great. Well, thank you. Thank you, Madam Chair.
Thank you. Other questions for this panel or the sponsor? I just have one quick question, I guess, for those of you that have been implementing this model through what sounds like a pilot project. How do you receive the referrals? What's the kind of patient flow? Like, where are the patients identified and how do they flow through?
You'll probably hear it from other folks who are testifying in this bill, but for us, they come from everywhere. But they're, again, in Baltimore County and Baltimore City, we have a lot of referrals coming directly from other providers in those jurisdictions, from hospitals, from community organizations, and as we mentioned earlier, veterans programs and services.
Madam Chair, if I could just add, I think you'll hear shortly from another CCBHC that's operating in Montgomery County, and they invested some of their grant funds in translation software so that they could address the needs of immigrant population. And so every community is going to be different in terms of where the referrals come from and what the referrals look like in terms of the populations.
It was sort of as though you anticipated my follow-up question, because I know in the FQHC world, a lot of the folks who utilize those services need services that might not be covered just in the core. So yeah.
I think the really positive to this program as well is that interaction and that connectivity to other systems. So it allows us to do the supports to places like the VA and other systems and invest in some of the infrastructure that's critical to make this work. And other states have seen tremendous success and fiscal notes much, much lower than the one you saw in this bill. In fact, a fraction of this.
Thank you. And I appreciated the chair pointing out some of the challenges with the numbers that we were looking at, because as you know, that number could be a little intimidating, but it is not anticipating the cost savings that come from preventative care. So,
and the good news is there's other states that have done this. And so we have evidence of how other places have done it. And we can certainly encourage our state to look at those states and how they've accomplished this. And they've been around for multiple years now.
We're all for not reinventing the wheel when it makes sense. All right. I don't see any further questions for the sponsor of this panel. Thank you very much for your testimony.
Thank you.
We'll move to Carrie Guthrie, Cheryl Neverson, and Pam Casemeyer. You can all come forward. All signed up in favor of the bill. Good afternoon.
Good afternoon, Madam Chairwoman. My name is Carrie Guthrie, and I am the president and CEO of Cornerstone Montgomery, the largest behavioral health provider in Montgomery County. And yes, I do come before you in support of Senate Bill 362. Since becoming one of the SAMHSA expansion CCBHCs in 2019, we have seen some amazing outcomes for our clients around access to services and reduction in hospitalizations. We added over 1,000 clients to our programs, including a second assertive community treatment team. We have seen emergency department visits and hospitalizations trending downward in 2020 and 2021, 59% and 36% respectively. In our ACT program alone, the county hospitals that we work with reported that we have saved the state over $2 million because of our ACT programs. We added CNAs and LPNs to our residential program to address the co-occurring medical issues that research shows leads them to dying 20 years earlier than the general population. And over the last 4 years, nearly 400 of our clients have received additional services for things like personal hygiene, nutrition, and medical follow-up. We expanded our outpatient clinic to serve children 12 and under, with plans to serve children as young as 5 years old. And we have also implemented an on-demand video translation program to meet the needs of our diverse community. We served an additional 45 clients who speak 21 different languages, including American Sign Language, Amharic, Arabic, Cantonese, Russian, the list goes on. We provide many services to people who are dually diagnosed with mental health and substance use disorders under our mental health accreditation. But as a CCBHC, we want to obtain our substance use disorder certification, which will expand access to more individuals eligible for our services. This model is the future of behavioral health, and it's time for Maryland to invest in this model for the lives of the most vulnerable. We respectfully urge a favorable report. Thank you.
Good afternoon. My name is Dr. Cheryl Neverson, and I am the Senior Vice President for Clinical Strategy at Volunteers of America, Chesapeake and the Carolinas, where we provide services for housing and homeless services, reentry, mental health, addictions treatment, and we serve over 3,000 Marylanders annually. In April of 2020, we were the recipient of one of these awards through government funding, and we were funded right in the beginning of the COVID pandemic. And we were able to make a significant impact on the lives of Maryland residents by increasing our behavioral workforce by 30 new hires. We were able to increase integrated behavioral health and primary care services. We reached over 810 individuals in the 2 years that we were established with the grant, both children and adults. And this was, again, in the height of the pandemic. We increased our outcomes, and we also increased enrollment in Medicaid and Medicare by 362 clients. We are one of those agencies that unfortunately did not get refunded for our CCBHC, leaving us at risk of not being able to continue our amazing work that this grant and this model allowed us to create. One of the key aspects of this model is that it allows providers to treat anyone regardless of their ability to pay. And just ironically, yesterday, I got a call from a community crisis center stating that they had a 17-year-old female who was undocumented and uninsured and who needed substance use treatment and therapy services. And they heard that we would serve anyone because of the model that we had. And today I said, yes, of course we can help you, because we're going to continue to serve these clients. But if this model is not funded, unfortunately, my answer soon would be, unfortunately, I'm not able to help you. And this is helpful for people in our communities that look like me. And so thank you so much for your time.
Good afternoon, Madam Chair and members of the Finance Committee. I'm here actually on behalf of a number of clients, the State Medical Society, the Academy of Pediatrics, and the Mid-Atlantic Association of Community Health Centers, strongly in support of this bill. I'm not sure I could give any additional better information than the witnesses before, who I think have done an excellent job. I do want to respond to one comment that you raised, Madam Chair, is FQHCs. This is in some ways analogous to the FQHC model. And the Mid-Atlantic Association of Community Health Centers was really excited when this bill came forward. Sometimes you would think, oh, well, this is competition. It is absolutely not competition. And in fact, in many states where this model has already been implemented, either FQHCs have chosen to reconstruct part of what they do to become CCBHC for the behavioral health side and on the somatic side, and or partner with CBCs in their communities that they serve to broaden the range of services. The General Assembly has spent so much time and effort to continuing to strengthen integration of care and access, regardless of ability to pay. Behavioral health is escalating issues, and you're really focusing. This is about as comprehensive an approach as you can get to meet a wide variety of needs in a very efficient way, and we'd strongly urge a favorable report.
Thank you. Are there any questions for this panel? Thank you very much for your testimony. Colleagues, that will conclude the hearing on Senate Bill 362. We're now going to turn to Senate Bill 237, Public Health Dental Services Access. Vice Chair Klausmeier.
Yeah, we're fine.
Good afternoon, Madam Chair and the rest of our wonderful committee, the best committee in the Senate. Senate Bill 237, Public Health Dental Services Access. In 2021, the General Assembly established a task force to study oral health in Maryland. We directed the task force to determine the barriers to receiving dental care for underserved populations in Maryland, such as poor, children, the elderly, immigrants, etc. The task force report identified these barriers for each population and made recommendations to eliminate or diminish these barriers to accessing dental services. Senate Bill 237 is taken from draft legislation prepared by the task force staff and implement some of the recommendation of the task force. The provisions include in Senate Bill 237 are: the bill will significantly improve the oral health of children by requiring that daycare and public school children receive dental screenings within 6 months of their first, third, and sixth, 9th, and 12th birthdays. The legislation will provide an incentive for more dentists and dental hygienists to work in underserved areas in Maryland. The bill does this by increasing the amount of loan assistance grants to dentists in return for a 3-year commitment that at least 30% of their practice will be devoted to treating Maryland Medicaid recipients. The bill will also make dental hygienists eligible to receive those grants. To help facilitate access to care among the underserved population, community health workers will be eligible to receive reimbursement when facilitating access to dental care. Senate Bill 237 increases Medicaid reimbursement rates on dental services by 4% and requires that those rates be reviewed annually. This will be an incentive to increase the number of dentists that participate in dental Medicaid. The bill will require the Department of Health to develop and distribute to dental practices plain language materials explaining various dental procedures and the importance of regular dental care to a person's overall health. The bill also states that the Board of Examiners shall require an applicant for an initial license or license renewal to indicate if they provide or intend to provide mobile or portable dental services. The board is directed to publish on its website a searchable list of dentists and dental hygienists that provide these services. Finally, Senate Bill 237 also sets up two studies. First, a work group convened by the department will study the establishment of grant or no interest program for dental providers to set up practices in underserved areas. Second, the Department of Health will conduct a study on dental provider participation in the Maryland Healthy Smiles program, which will include a review of administrative issues relating to enrollment of the providers in the program, as well as incentives to encourage provider participation. I am accompanied here by Dan Doherty from the Maryland State Dental Association, who can provide more information and help answer questions. I know this is a large bill, and I appreciate the committee's attention to my testimony. Thank you for your time, and I would like to request a favorable report. And I also have a few amendments so far. We've been working on this, and so I would like just to say what the amendments do so that the committee has some bearing on what's going on as far as the bill goes. After speaking with the representative from Maryland Medicaid, it was brought to my attention that there will be no matching federal funds for care provided to undocumented persons. So the amendments strike that portion of the bill. So that will be gone. There were also concerns about the timeline in the bill was much too ambitious. So the amendments delay the implementation of the screening requirement by 1 year to July 1st, 2024. Also, to give the department more opportunity to study the use of community health workers, the requested amendment will delay implementation of the community health workers part of the bill until January 1st, 2025. I have also requested an amendment to clarify that the dental practices plain language materials include age appropriate children's materials, because I felt like that was very, very important so that the children know exactly what's going to happen to them when they have to go to the dentist, because I think many of us are in that same situation that we, no offense to dentists, but we don't like to see it too often. So, but, and because fear is in the unknown. So for children, it's very, very important. So they know exactly what's going to happen and how it's going to go. So with that, if anybody has any questions. Okay.
Thank you, Madam Chair, members of the committee. My name is Dan Doherty. I represent the Maryland State Dental Association. And I want to thank Senator Klausmeyer for sponsoring this bill. She has been a tireless advocate for oral health in Maryland over the years. I want to focus on primarily one or two issues in the bill. We currently are undergoing a crisis where there is no operating rooms or virtually no operating rooms available to treat pediatric and special needs patients who are suffering from infection and pain. And infection in dental health is very dangerous because that infection can go from the mouth to the brain and elsewhere. At the present time, we know there are at least 5,000 children who are in line to get treatment, and there is none available. The first part of this bill, which deals with the dental screening, is what my mother would have called an ounce of prevention. If you get the children screened at intervals, you can detect early onset of caries and treat them then, so you don't end up when they are 12, 8, 9, with 10 caries that have to be treated with serious abscesses. And in having those screenings, you can also distribute the plain language materials that are referred elsewhere in the bill, where the need for good oral health and how to obtain good oral health is explained to the parents, and that information can be carried forward. The other provisions of the bill, I think, are very necessary to increase access. We need to increase the providers who participate. And I would urge you and to have a favorable report, and I thank you for your time.
Madam Chair, members of the committee, my name is Dr. Charles Doring. I'm a general dentist in Rockville, Maryland. I am also the Legislative Affairs Committee Chair for the Maryland State Dental Association. I'm also was on the task force that came up with your report that was published December 1st. I hope everyone had a chance to read it. I'm also on the medical staff of the Hebrew Home of Greater Washington, where we see patients in skilled nursing facilities. I also do portable dentistry, see the homebound as well in my rather busy practice. So in particular, I do like the section. I like the whole bill. I think it does a lot to help Marylanders get much better oral health care. But I do like that publishing that searchable database for our patients. I do want to bring up some issues in discussion with the Medicaid staff in the state of Maryland that have been brought up in the past. And as Mr. Doherty stated, prevention is the key here. And you should have gotten in your packet a Pediatric Oral Health Research and Policy Center. And there's a whole section on early prevention saves money for families and communities. So I think that's key, and I encourage you to read that. The second objection that I've heard is penalties. The bill does not state any penalties for not getting a dental exam or screening. As a matter of fact, the American Association of Pediatric Dentistry policy states, oppose regulations that would prevent a child from attending school due to non-compliance with required dental examinations. The screening exams are an opportunity for dental hygienists and dentists to reach out to the patient and the caregivers, the parents, and do education. Just to give you an example, Lucia came to my office with dental caries on 2 teeth here in this picture. She had 10 of them in her mouth. She's 5. If she'd come in at age 1, we would have had a much better outcome. So I asked for a favorable report on Senate Bill 237. Thank you.
I would like to thank the chair and the committee members for the opportunity to speak in favor of Senate Bill 237. My name is Dr. Anu Tate, and I practice at Children's National in Washington, D.C. I received my MPH from Johns Hopkins University, and I've been practicing at Children's for 20 years, and I've had the ability to see firsthand the effects of untreated tooth decay in young kids. I've seen children with infections. We've seen avoidable hospital admissions, time away from school, parents' time away from work, all for a preventable disease. And so I agree with my colleagues here. One of the most important components is the opportunity to have early preventative visits. As a former trustee for the American Academy of Pediatric Dentistry, I have advocated for the age 1 dental visit, mainly because it's an opportunity to prevent. As you've heard a theme already today, a pound of prevention, an ounce of cure, whatever the theme is. But you know the idea, right? That we really want to prevent problems is much easier in little kids than trying to treat them for all the reasons that we've talked about. It's an opportunity for me to build a relationship with a parent, to build trust with a parent, to come up with a individualized plan about how we can partner together to prevent dental disease, to think about fluoride therapy, to do behavior change. Any child that has early untreated dental decay is going to be 3 times more likely to have dental decay with their permanent dentition. So this is a huge opportunity to prevent suffering down the road, to prevent the costs that go along with treating the adult dentition and dental decay. I love seeing kids in my practice. I love seeing the parents. They're full of questions and want to be engaged. We want children to be pain-free. We want them to live in an environment where oral health is valued, where parents can partner together and they have the skills and knowledge to create a caries-free environment for their families. So with that, I ask for a favorable report on Bill 237.
Good afternoon, Madam Chair and committee members. Thank you for the opportunity to speak. My name is Dr. Alexandra Fitzgerald, and I am a general dentist practicing in Frederick, Maryland. I currently serve as the president-elect of the Maryland State Dental Association. I graduated in 2018. from the University of Maryland School of Dentistry. And upon my graduation, I went immediately into private practice. I would like to expand upon the cost of dental education. Dental education in the state of Maryland is the most expensive professional school career. I also submitted written testimony, including an article from the Journal of the American Dental Education, of the American Dental Association, and speaking just about the impact that student debt has upon post-graduation career decisions, whether that be going into private practice, going into a DSO environment, specializing, accepting medical insurances, et cetera. But dental school education in the state of Maryland, looking at 2019 numbers, the school has not updated their numbers since then, was over $100,000 more expensive in terms of the average dental school, in terms of the average student debt load than medical school. It was $253,000 compared to $151,000 for equivalent four-year degree programs, in my opinion. My tuition alone has increased by 50% when I compare when I started as a first-year student in 2014 compared to the students that started this year. When deciding what you're going to do post-graduation, whether you're going to participate in a program such as Maryland Healthy Smiles, you need to be able to sustain your living expenses and everything that is going through that. I can also speak that for me personally, I work 6 days a week in order to pay my bills. Having this favorable report for Senate Bill 237 would make a large impact in the number of providers signing up for Maryland Healthy Smiles, but more importantly, it would really expand the loan assistance repayment program. Thank you.
Thank you. Senator Reedy.
Thank you, Madam Chair. And this question is probably for anybody on the panel. What is the cost of a dental screening if someone doesn't have dental insurance?
Thank you for the question. On screenings, I look at Anne Arundel County, Dr. Lucy Pesatini. She's the dental director in Anne Arundel County. Her team of dentists and hygienists go in and do the screenings. I believe it's no cost to do the screening. They go to the screenings at the school. They go to the school. I also want to shout out to dental hygienist Sarah Cruz, Chop Tank Community Health Systems. She also goes into schools, particularly it's mandated for these exams in Head Start programs, but they also provide it. So the the screenings are maybe less comprehensive than if you were to come into my office, do a full-fledged exam with x-rays, but at least we're doing a screening and giving feedback. Oh, this child can brush a little bit better, or this child has dental disease, and here's a referral to an office that maybe participates in Maryland Healthy Smiles. So if they're eligible in the Maryland Healthy Smiles, the cost for the dental exam for the participant is zero. So, and we have very low utilization currently for children in the Maryland Healthy Smiles by age. If you look in Montgomery County stats, it's less than 1% of Maryland Healthy Smiles children get an exam by age or at age 1. And it goes up to about 24% in that age bracket 2 to 3. By age 5, it may be 45, 50%. But by then, like little Lucia here, the caries is already rather rampant.
So maybe I am not completely understanding the bill. I was reading through the fiscal note and looking at the bill. So we're going to require screenings at ages, I won't read the whole bill, but basically several times during elementary school. And then we're also requiring, I was confused about how the part about after the child's first birthday, third birthday, are we mandating that for every child in the state in this bill?
Yes,
So every child in the state under this bill would have to get a screening within 6 months after their first birthday.
If they are attending preschool.
If they're attending a preschool
or
a
in daycare.
daycare. Now, but is the bill, what I'm not clear on, I thought the bill was providing services to some extent, but you're telling every child would be able to access a screening provided for by
Maryland
These-
Healthy Smiles.
Maryland Healthy Smiles, no matter age, income level.
No, to be eligible for Maryland Healthy Smiles, you have to qualify for Medicaid.
Right, I knew that.
So people who are not in Medicaid, it would be fee for service. And my understanding was a screening's like $40.
Right. Right, okay, so we're not. So children in school, they would be able to, any child would be able to access this in the school? They'd be
No.
able to do a screening or no?
No, not all counties provide the screenings in the schools. That's actually.
And this bill isn't adding to that. This bill is just requiring it, but not.
This bill is requiring, but without any punitive provisions, that children across the state do what's being done in Anne Arundel County and a couple of others.
Okay, I believe dental hygiene and dental health is really important. I know we've had some very bad circumstances. Little concerned about just how far this bill stretches into people's personal choices and lives with their children, but we could maybe talk about that offline. I think the goal is good, but if you don't have dental insurance, going to a dental screening, I don't think you just walk into a dentist's office and get a screening for $40. I could be wrong. And no offense, you all do a great job. I was just at my dentist yesterday, getting a cleaning, taking care of my teeth. So, but I think we need to, there's probably some good in this bill. I think there's a couple things I have some concerns about, but we can talk offline. Thank you.
Yes, Senator, because I think there are analogies with what is already required medically in the schools that's mandatory. And this could be used at least in the elementary schools on the same form.
Thank you. We'll go to Senator Lamb, then Ellis, then Guile. Senator Lamb.
Sure. Thank you, Madam Chair, and thank you to the panel. And I want to preface this with, I'm all about prevention. As a preventive medicine physician, I get it. I think it is really important. I think some of the provisions in this bill, and there's a lot packaged into this bill, even in what you just kind of touched on, does give me some pause. When I look at, for example, this letter from the Maryland Department of Health as a letter of opposition, and just to summarize, they say that they're concerned because there are not enough dental providers to deliver required screenings to children. As of August of last year, there are only 193 active pediatric dentists in Maryland statewide. And so, while I understand the importance of dental health screenings for child health, I'm not sure that there are actually sufficient dental coverage in the state to make this possible for all families to meet this requirement. How do you respond to that concern? And, are there ways that families without access to a dentist can deal with the requirements of this bill if they don't qualify for the SMILES program?
Thank you for the question, Senator. The first part on the number of providers, I would say, and probably Dr. Tate would agree as a pediatric dentist, most kids see general practitioners for their care. I love seeing kids. I'm a general practitioner. I've seen them from 3 months with neonatal teeth to 103. So I'm comfortable with seeing kids. And I think most, Dr. Tate actually teaches courses for general dentists to do proper exams and treatment for kids and use of things like silver diamine fluoride. So that, and certainly the other thing, as we discussed, is outreach. The Maryland State Dental Association would be committed to working, this is National Give Kids a Smile Month, by the way, where we've gone out and done education programs at various schools around the state just this month alone. So we would team up with models like they do in Anne Arundel County and Chomp Tank to get these kids screened appropriately. And sometimes it's just a check off on a medical clearance form that they're already filling out, but we want to make sure that it's done. And unfortunately, you say, well, the physician, maybe the pediatrician could do this. If that's the case, we wouldn't have 3,500 to 5,000 OR block kids waiting for OR block time to take care of rampant decay like Lucia here. So we're committed and raising all the providers we can And a lot of it's going to be done by general dentists.
I mean, with all due respect, I think you're missing my point with the pediatric dentists. I agree that not all of them have to be done by pediatric dentists, but there's already a shortage of dental providers out there, just general dentists generally. It can be hard for folks that even have insurance to be able to get an appointment with their dentists. And you point out that pediatricians can't do this. I think it's also important to note that many more pediatricians take Medicaid than dentists that take Medicaid. There are very few dentists out there that take Medicaid, and I think you're aware of that concern as well. When it comes to the community health worker component of this and requiring Medicaid coverage for dental community health workers, I'm all for community health workers. When I was in the House, along with former Senator Shirley Nathan Pulliam, established the community health worker requirements here to allow CHWs to be able to practice. This piece, however, only focuses on carving out dental community health workers to support them through reimbursement, which could be very costly, including what's cited here in the Department of Health's letter. And it's also not exactly clear how community health workers that are dental community health workers could be very clearly segmented. Are they people that are just helping a person find a dentist, helping them, be able to link them with an appointment? And I think there's concern there with the lack of clarity with definition of what a dental CHW would be doing. That really blows up the cost of this and makes this a little bit untenable. And that's why even for community health workers generally, there is no reimbursement mechanism because it was too hard to figure out a couple of years ago when we were trying to do that. Can you respond to the concerns with actually allowing dental community health workers to be reimbursed?
Senator, if I could try and respond to that, because I had the conversation with Medicaid on that issue. We were informed that this new secretary is going to be looking at utilizing community health workers across all spectrums of Medicaid and services rendered. And in response to that, one of the amendments that Senator Klausmeier has had prepared would delay the effective date to January 1, 2025 to allow that plan of the secretaries to go into place and include dental and then go forward from that point.
Okay. Well, to me, that sounds like we're putting a little bit of the cart before the horse, that we're trying to pass something to allow reimbursements for dental CHWs without even having figured out the entire kind of program for CHWs generally. I do share Senator Reedy's concern about this requirement for all parents. I'm a new parent. I have a 17-month-old. I did talk to my dentist about what we need to do for our daughter when it comes to them seeing a dentist. Our dentist told us that you bring them in an early age, it's really just kind of acclimating them to the dentist. You sit them in the chair so they don't get scared. You show them how to use a toothbrush. This would require for all parents after age 1, before 18 months, ours is 17 months. I'm almost already out of that window, that if we want to continue childcare, which I need to do, that they would have to see a dentist before that. It's an unfunded mandate on all parents across the board that have to use childcare. Is it not?
No, it's not punitive. It does say they're required, and that is true in other states. But in reality, if they do not go, there is no ramifications for that.
So we're going to put something in statute with no ramifications with the understanding that people won't comply?
You're going to put something in statute with a strong indication they should comply, but you're not going to punish them if they don't.
Okay. That sounds another bit like the cart before the horse to me, but I'll pause there. I think there's a lot in this bill that, as I mentioned, kind of gives me pause, and I think there was a lot thrown into this that came out of the task force that I think there was, the kitchen sink and more kind of put into this bill, and all of that I think is probably a bridge too far to stretch, in my opinion. Thank you.
Thank you, Senator. Senator Ellis.
Thank you, Madam Chair. Just a few technical questions. So I think, Dr. Doherty, you were saying that there are 5,000 children who are awaiting dental treatment.
There are
what is Maryland and one And what?
This is in the state of
the state of
Maryland.
Maryland.
The House has been looking at this issue through web Zoom meetings for about 6 weeks or more. And during that time, we were asked to do a survey in 24 hours of our dentists about how many children do you have that are waiting in line to try and get into an OR. And of those 108 that responded, it was 5,000 children. And that's Baltimore, Montgomery County, Howard County. It's all over the state.
Okay. And I think you threw out a number for 35,000 kids in the emergency departments. I don't know who did that. So
No, 3,500 to 5,000 is what we were saying that we're in line to get into an operating room.
operating room. Okay, that's a dental operating room.
No, it's a fully equipped operating room within a hospital context, or it could be within an ambulatory surgical facility.
So these are the more
These are hospital,
yes.
yes,
What's the term? Severe cases?
acute.
Acute cases, yeah, where lack of dental treatment is causing potential
Yeah, we were told
Terrible
that
effects.
85 to 90% of those children had either severe infection and or pain.
yeah. And so this is these between 3,500 and 5,000, they didn't have access to preventive care, regular cleanings and stuff like that, which escalated. Is that the issue you think?
For whatever reason, their dental health was ignored.
Ignored.
Whether it was because they hadn't been educated properly, because of lack of finances, because there are an awful lot of poor people that don't apply to Medicaid for a variety of reasons. Some because of immigration status, that type of thing.
Okay, yeah. So obviously we need to fix that problem. And a quick question with Dr. Fitzgerald. You mentioned with the DSO environment, how it's difficult as a new dentist. Could you tell us what that is? What's a DSO environment? What makes that environment different from?
Private practice. So a DSO is a dental support organization. It's also quote unquote corporate dentistry, where oftentimes the management is done by a non-dentist. So sometimes the dentist in the practice is a partial owner. Sometimes they're an associate, such as myself. There is a stigma with dental support organizations in other states, particularly having not the most ethical practices. I'll say that. Part of the reason that I went into dentistry as opposed to literally any other profession is because I eventually wanted to be a small business owner. I wanted to be able to care for my community, help my community. And the way that I personally would want to do that is by oral health care, which is not as commonly known as going to a physician. Growing up, my mom is from Panama, from Central America, and advocacy and just community support in general was something that was really crucial and fundamental to my childhood and my upbringing. And when we would go and visit, I would talk to kids as a child myself and discuss, like, here's how I brush my teeth. When I was an undergrad, I went to University of Maryland, College Park. I started an organization called the Student Dental Advisory Board, and it was a community service organization where we went to local elementary and middle schools. And I'll never forget the day that we were passing out toothbrushes and a little girl squealed in delight because she was just like, I only am allowed to brush my teeth on Tuesdays. And I said, what do you mean? Why don't you brush your teeth the other days? And she said, I have to share a toothbrush with my siblings. So I gave her more toothbrushes. But this is the environment that unfortunately some of our citizens are living in.
Thank you.
Thank you, Senator. Thank you for your responses. Senator Guile, then Senator Mounts.
Yeah, thank you, Madam Chair. I'll echo what everybody else is saying. I'm all for dental hygiene. Let me just preface that. But I did want to get back to, I know that you keep insisting that this isn't quote putative. However, when I'm looking at the text of the bill, it says, for example, with respect to childcare, it says the parent or guardian of a child, et cetera, shall provide to the family childcare home or large family childcare home evidence that the child has had these screenings. The word shall is in there. And now if I'm a lawyer that's representing a daycare, I'm going to tell them, you need to get proof of these screenings. So, or you can't let the child in. So I'm just curious why you don't think that there aren't ramifications for the parent.
The last statement, though, isn't correct, with all due respect. You need to get it, but if you don't get it, it's not a bar to the child coming in.
Okay, and I assume that's maybe a later on in the bill that I'm not seeing.
No, it's the way there's no penalty, there's no requirement that they exclude the child. The bill's silent on that. But I
Okay.
will say this, Senator, one of the issues raised by medical assistants was that issue, and we are in the process of trying to work on language. So it doesn't seem as much of a mandate and address that. We have not gotten there yet because every verb we've tried to use, the bill drafting has said that, well, we have to use shall. So we keep coming back to where we are. So
Yeah,
it's wordsmithing at this point on that issue.
sure, and shall is frankly a mandate. I mean, whether or not, what your interpretation may be, but just so I understand it too, I mean, also the parent of a toddler who I gotta admit has not yet seen the dentist, although I've spoken with the dentist about it. But it says, for example, that they have to have had this screening by the first birthday and by the third birthday. I mean, what if you got a child that's starting to go to the daycare and hasn't yet seen it? Do they need to catch up? I mean, they can't catch up by that point. I mean, they'd still be able to go to daycare. Is that what you're saying?
Yes.
Oh, okay. And then if I could just add a little bit of other commentary to Senator Reedy's point earlier about the cost of screenings. I mean, I know, or what Senator Lamb, the point he was making earlier about the quantity of dental providers. Just from the perspective of somebody who's had dental insurance, I know I was enrolled in my husband's TRICARE dental, and I'm sure you're familiar. They switched to providers that was doing the TRICARE dental, and because of the low reimbursement rates, a lot of dentists did not want to do it and got off of it, and it was very challenging for military children to get the dental screenings because they would have to travel very far outside of their area because no dentist wanted to take that insurance. So I'm just saying that, regardless if the parent has dental insurance or doesn't, it's challenging and it's expensive in order to comply with that. So that's my commentary. Feel free to respond if you'd like, but.
Well, if it would have been a commercial policy, unfortunately, it's government and it's excluded from state regulation. But in a commercial policy, you have the right to go out of network. You have to pay more, but you can go out of network to see another dentist. But when you're dealing with a governmental or an ERISA plan, you don't have those options.
Well, thank you. Appreciate it. Thank you.
Thank you. Senator Mounts.
Thank you, Chairman. I don't want, you've had a lot of questions on this bill, but and some heavy eyebrows. I think my father was a dentist. He'd probably be smiling from ear to ear right now looking at this bill. But the counties, did you testify? Did someone testify that some counties currently require this?
Anne Arundel County provides these screenings, and I think a couple of others require it, but it's only 2 or 3 out of the entire state.
So Anne Arundel does, and there are a couple other counties that do it also?
Yes, although most of those are directed to elementary school only and don't deal with preschool or with daycare.
Is the bill modeled after what's done in Anne Arundel County, or is this?
It was after these 1.5 to 2 year study by the task force. That was the language they came up with to recommend it.
So this is the task force?
It's a very small portion of the recommendation the task force had to try and improve dental access in various populations. Obviously, this is directed to children and the poor more than any other.
Right. And why did they come up with those? What were those ages? Is that a medical? Are those benchmarks?
That's the recommendation, as I understand it, from the American Pediatric Dental Association.
Yeah. And then listening to the testimony in the bill, and when I first heard the bill, I was like, I interpreted it, I think a lot of the way there's some of the testimony that it's a mandate. your child isn't going to go to daycare, your child isn't going to go to school unless they have this screening and proof of it. But the more I heard the testimony, it sounded to me as if the bill is more intended to get more children access to dental care. Is the bill supposed to be like we're forcing the parents, or is it to get more children access to dental care?
It's trying to get the children dental care, but I think in order to do that, you have to put some requirements or some impetus behind the parents to do it.
Right, because I know firsthand the challenges of getting children dental care who don't have access to dental care. How does this bill help a child who otherwise wouldn't be going to the dentist? How would this bill get them to a dentist?
Well, with the screening, and I think we need to clarify, there's a dental examination, which Dr. Doring referred to, which includes x-rays, et cetera.
Mm-hmm.
And there's the dental screening, which is basically looking at the teeth, the mouth, charting and determining if there are caries or other dental disease. It's a lot less comprehensive.
Mm-hmm.
And this bill requires the less comprehensive screening. And the hope is that if you get them screened and you can detect the caries, you can then talk to the parents about the need to have those taken care of, work out financial arrangements if they don't have insurance and they're not on Medicaid, and get the work done. And then when they're 8, 10, or 12, they're not in that line trying to get into an operating room to have serious infection taken care of.
Would the bill get more people involved in providing the screenings that already provide the screenings?
I would think, we would hope, where other portions of the bill are intended to try and increase the number of dentists that can afford to participate in the Medicaid program.
And MABE's got testimony, the boards of education, they've asked to be excluded from having to collect the information from doing the screenings. I'm assuming something like that wouldn't be too controversial, would it?
Well, currently they have to collect a lot of medical information, and there's a form that was developed. You could add this dental thing as a new column and it's another checkoff.
Okay.
So it really isn't that complex.
Okay. Those are my questions. Thank you.
Thank you, Senator.
Again, my father's smiling.
Thank you. Senator Lamb for a very brief question.
All right, thank you, Madam Chair. This is giving me the opportunity to read through some of the favorable with amendment testimony. And I'm trying to be helpful and being constructive because they have some amendments that are suggested in here. However, a lot of the amendments kind of remove the core part of this bill about the whole requirement component. You know, when I look at the Maryland Community Health Systems letter, which is favorable with amendments, that they suggest that the department convene stakeholders and study the issue further. That's the amendment that they actually suggest. MABE, as Senator Mouts has mentioned, asked to remove the whole requirement of reporting. And then the Education Advocacy Coalition also is looking with concern about how this could affect children with disabilities. Again, asks that this be amended to remove them out of this. And then the Public Justice Center, also favorable with amendment, is asking respectfully to strike the language and replace it with the requirement that MDH and MSDE collaborate on educational materials in an outreach program for families, which I think is probably much more palatable. You know, it sounds like everyone was here was too nice to say no, and they all came in favorable with amendments. Would you be open to some of these amendments to remove some of the more onerous parts of the bill?
We are more than amenable to sit down and discuss with all the stakeholders. What we can finally agree to, I'm not sure at this point. Totally removing a mandate is somewhat concerning, but there may be more than one way to address the issue.
Okay.
Oh, I'm sorry.
Thank you, Madam Chair.
No, what I would just like to say, I realize that everyone has lots of questions, but the bottom line is somehow or other, we have to figure out how to get these children with their oral health care going when they're young, instead of waiting until they're 6 or 7 and need fillings and all of that. And if we look back a couple years ago, well, several years ago, how the tragedy happened with that young man who died because he did not have his teeth fixed. So whether this is the vehicle to do so, or whether it is, and if we can get some kind of collaboration and just try to figure it out, whether it's just information to get out to the parents when the child's born, get your child to the dentist or whatever. So this is what came out of the task force. So thank you.
Thank you, Senator Kramer.
Thank you, Madam Chair. So quickly following up on these favorable with amendments, at some point, isn't it time when we've studied something enough that perhaps it's now time to act decisively and move forward based on the studies that have already been done? And would you not agree that very often educating the public is very challenging, and more often than not doesn't result in the intended outcomes? Isn't that so?
Yes.
Can I?
Thank you for that. Thank you, Madam Chair.
Thank you, Senator. Let me just thank this panel for your responses to the questions. As someone who's just been listening to all of the dialogue, what I hear very clearly is that there is a problem that's been identified and a number of solutions that are proposed in this legislation. Sounds like the committee will be having some conversations about this bill and the problems that you all have helped identify. If I were to ask a question, and I'm not, I was going to talk a little bit about the loan assistance repayment program. And ma'am, you shared about the needs, financial needs of those students that pursue dental education. And I saw a portion of the bill that talked about recruiting new providers to the field. So we can talk about that and other issues offline. We do have other witnesses signed up to testify. So thank you all very much for your
Thank you,
testimony.
Madam Chair.
We're going to call forward Caitlin McDonough, Michael Patty, and Pam Casemeyer. Good afternoon.
Good afternoon, Madam
We're on
Chair.
our second bill of the day.
I hear you. You want me to go ahead? Good afternoon, Madam Chair, members of the committee. Caitlin McDonough here today on behalf of two organizations, the Maryland Dental Hygienist Association in support, and also Benefis, which is a dental support organization that supports 9 majority Medicaid practices in the state. I'm going to adjust my testimony a little bit. I do have written in the packet. We're in general support, but we certainly stand ready to work out some of the kind of details and nuances of the bill, particularly as it relates to dental hygiene practice in the state and shortages that we're seeing. I think to address some of the questions around the screening, what we're looking for is Maryland's done a lot to kind of educate the public on the importance of oral health as a part of overall health. So when we see medical screenings being required for schools, sports, and other entities, there is a tendency for parents and families to kind of underestimate the importance of oral health. Whereas we actually see students like your children suffering from more oral health problems than maybe your traditional medical health problems. So I think parity in those two areas of health is where we're trying to get there. But happy to work with the committee to kind of tweak what that looks like as far as mandates with organizations. Love having the hygienists in the loan reimbursement programs. I think something that's facing both dentists and hygienists is the lack of hygienists right now. It's a big driver of cost in dental care because when there are shortages, you have to pay people more to get them. So getting more people into the education and into the profession is key to address those network issues and also do these increase services in these practices. And I certainly don't want to overlook the Medicaid investment that's in the bill. It's a really important piece. Medicaid dental service costs have gone up astronomically in recent years because of PPE, because of those shortages in staff we've discussed and other supply chain increases, but reimbursement rates are way behind. We had an increase last year. We had not had one in a decade before that. That is important to have the network we need. So we're in support and stand ready to work with the committee on any amendments. Thank you.
Great. And Michael Patty here today for the Maryland Dental Action Coalition. I want to thank the vice chair for meeting with me briefly to talk about one of our ideas to add another group into this bill. We've talked a lot about dentists and dental hygienists. We just want to bring to the committee's attention dental assistants that also play a key role in getting that oral health care. My written testimony just highlights that we're proposing adding in this group to study to see if they should reap the rewards of a tuition reimbursement program as well. I have other suggestions in written testimony. I don't want to delay this day any longer, so feel free to look at my written testimony, and any conversations about the bill, feel free to involve us as well.
Thank you very much. I don't see any questions, so thank you very much for your testimony. I believe we have one virtual witness, Dean Mark Reynolds. Good afternoon.
Good afternoon, Chair Griffith, Vice Chair Klaus Meyer, members of the Finance Committee. I serve as Dean of the University of Maryland School of Dentistry. Over the last year, I served as co-chair of the Task Force on Oral Health in Maryland. The task force was established during the 2021 legislative session by passage of House Bill 368 and Senate Bill 100 to conduct a comprehensive multidisciplinary assessment of oral health care in the state, including access to care and other systemic limitations to receiving dental services, to inform strategies to improve access to care and to make recommendations to address current and emerging oral health challenges. I'm pleased to share that the Oral Health Task Force submitted its final report to the governor on December 1st, 2022. As co-chair of the task force, I want to extend my strong support for Senate Bill 237, which aligns closely with the recommendations found in the report. Among the most consequential recommendations proposed by the task force relative to pediatric care is in the implementation of a statewide mandatory dental screenings for children ages 1, 3, 6, 9, and 12 as a requirement to enter childcare or the public school system. Equally aligned components of the bill include increased public education on the importance of oral health for children and adults, addressing Medicaid reimbursable procedures and services, and expanding the Maryland Dent Care Loan Assistance Repayment Program to include dental hygienists, and as we look to the future, potentially others. While Maryland has made much progress in the last decade to improve the oral health status of its residents, access to care remains a significant concern. Oral health is a critical component of overall health, and sustainable strategies to improve access to oral health care are imperative. We at the University of Maryland School of Dentistry are excited to continue our work to advance oral health and improve the quality of life in Maryland communities, particularly those most vulnerable. Thank you for your consideration.
Thank you. Are there any questions for this witness? Thank you very much for your testimony. I saw Pam Casemeyer just come in, and we had called you a minute ago. Or did you want to come up very quickly?
Thank you so much, and I so apologize. It's not lack of interest or in this bill. I was actually on the witness stand in another committee, so I apologize. Pam Casemeyer here on behalf of the Mid-Atlantic Association of Community Health Centers, which, as many of you may know, maybe not all of you, is the primary care organization dedicated by her. So its memberships is all the FQHCs, federally qualified health centers in the state, and other community services. I won't add to anything. We were here in support of this bill. Dental access is obviously a major issue. There's multiple components of this bill. Some are not really relevant to the FQHCs, like what you do with the school screenings or not. We're not for or against. It's not our expertise to evaluate. But I do know workforce issues like for dental hygienists and the like are a big challenge right now. So there's a number of provisions in this bill, most of which we feel would move that access forward.
Thank you. Senator Lamb.
A clarifying question. So the Mid-Atlantic Association of Community Health Centers, are they favorable with amendments or favorable to the bill?
Well, I don't know if I would say favorable with amendment, because there's certain parts of the bill that we really don't have expertise in. So I'm not here to say it's good or bad. They don't want to impact the dialogue on that section. So for example, the section about providing parents providing screenings to schools, that's not their space. So they're not here saying take it out. They're not here saying keep it in. They wanted to voice their overall support for multiple provisions. I don't think they have an opposition to any provision. I know there's been some other testimony about clarifying more resources and safety net areas and those kinds of things. We're strongly supportive of any clarifications like that, but we're not here with the specific amendment.
Okay, so there are provisions they support, there are provisions where they're maybe agnostic or something.
Agnostic is probably the right word.
Okay. You
Yes.
threaded that verbal jujitsu very well.
Yes, agnostic is probably the right word. And it's not their space to comment.
Thank you very much. I don't see any additional questions, so thank you for your testimony.
Thank
And
you
that
for the time.
That will conclude the hearing on Senate Bill 237. Colleagues will now turn to Senate Bill 255, which is Senator Hester's Public Health, Home and Community-Based Services for Children and Youth. Good afternoon, Senator.
Good afternoon, Madam Chair. I do have a panel with me. Well, good afternoon, everyone. Chair Griffith, Vice Chair Klausmeyer, members of the Finance Committee, thank you for your consideration of Senate Bill 255. As we discussed last week in this committee, all of you are personally familiar with the mental health crisis impacting our youth. This committee has also heard about the frequency with which Maryland's children end up staying in emergency departments long after they're ready for discharge, often due to the absence of a comprehensive, accessible plan of care once they leave. This bill before you is designed to bring immediate help to a specific subset of those children. A bit of history that will help to explain this bill and why I'm here today. Prior to 2014, the state of Maryland supported approximately 300 to 400 children per year with serious mental health conditions, including those with a high risk of harm or aggression, with a statewide coordination of support services. Then in 2014, that program was replaced by the 1915 I program covered by Medicaid, which was designed specifically to serve children with serious mental health needs in order to preempt an emergency room visit, hospitalization, or other higher levels of care. Now, this program was intended to reach at least 200 children a year. However, between fiscal year 19 and fiscal year 21, this program served just 34 Maryland children. Let me say that again. We went from serving between 300 and 400 children prior to 2014 to a program where we anticipated to serve 200 children, and it's only served 34 between the last 3 years. So clearly it's not working as intended. The Maryland Department of Health also recognizes the need to improve this program and even expanded eligibility requirements in 2019. However, the number of programs served by the program, the number of children served by the program continued to shrink. Strict eligibility criteria, both financial and medically necessary, as well as a catastrophically low reimbursement rates, are driving this lower level of utilization. Additionally, families are often referred to the service when a higher level of care, such as residential treatment, is needed. Diversion programs must be accessible to families before a higher level of care is needed. So what this bill does is it takes into consideration what has been learned to restore the balance of the children's continuum of care. Specifically, it requires the Department of Health to do 4 things. First, it addresses numerous known barriers to the 1915 I utilization. Second, it requires funding for high fidelity wraparound services and evidence-based practices at rates that are commensurate with industry standards. Third, it funds targeted case management services for an additional 50 children who are currently not eligible for this service due to having private insurance. And fourth, it funds a value-based payment pilot to treat children with intensive needs, which incentivizes outcomes such as hospital diversion and family preservation. Investing in a stronger 1915 I program is actually a cost-effective strategy. In fiscal year 21, the program costs an average of about $2,500 per child. This is only 1/10 of the average hospitalization cost, $26,000 per child, and just 3% of the average residential treatment cost, $77,000 per child, sorry. So basically, by diverting children into this program, it saves the state money and it makes the families and the children's continuum much better. So there was a drafting error in the bill as written, which I wanted to draw your attention to. And if you look at page 3 of the bill, the error, the amendment that we are offering today simply strikes lines 24, 25, and 26 of the bill. Now, those three lines are quite powerful three lines, and we believe they're responsible for the high fiscal note and also responsible for the letter of concern from the Maryland Department of Health. And once again, this is a drafting error. So we believe if we correct it, it will drastically reduce the fiscal note and also eliminate the concerns from the Department of Health. So in closing, let me just say that the legislation will strengthen the continuum of services designed to keep children and families out of crisis by providing them ongoing community-based and in-home crisis supports when they are needed. I do have a full panel of subject matter experts here to answer your questions. And for these reasons, I would respectfully request a favorable report on Senate Bill 255.
Good afternoon. Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm the Director of Public Policy with the Maryland Coalition of Families. MCF provides family peer support and navigation services to families who care for a child, youth, or adult with behavioral health needs. I'm here in strong support of Senate Bill 255. So the bill is the #1 priority of the Children's Behavioral Health Coalition. The goal of Senate Bill 255 is simple. To take a number of measures to improve the targeted case management and 1959 programs. Maryland has dramatically reduced its continuum of care for children and adolescents with mental health needs. This is most marked at the top end of the continuum, where children with the most intensive needs are stuck in emergency departments for days or weeks or even months, or are stuck in hospital psychiatric units, or are stuck in residential treatment centers, owing to the absence of intensive community-based programs to charge them to, programs which could have kept children out of these institutional settings in the first place. In their effort in 2014 to make wraparound services Medicaid reimbursable, previously in Maryland, high fidelity wraparound had been funded with federal grant dollars and state general funds. The department developed 2 alternative programs that have simply not been functioning well. The problems with the targeted case management and 1959 programs are many: low enrollment, inadequately trained staff, high turnover of staff, a very limited array of services, nothing like what had originally been planned for the program, low Medicaid reimbursement rates to providers, resulting in no evidence-based practices being provided, low family satisfaction, and a bureaucratic maze of paperwork that needs to be completed for a child to get enrolled in the I. You've heard from the sponsor about positive outcomes other states and jurisdictions have enjoyed when they implemented high fidelity wraparound. There is dramatic declines in utilization of emergency departments, inpatient units. And I would just say, I'm happy to answer any questions. We urge a favorable report on Senate Bill 255.
Thank you, Madam Chair, members of the committee. My name is Kevin Keegan. I'm with Catholic Charities of Baltimore, and we are here in strong support of Senate Bill 255. I appreciated the senator's comments to open this up and Ms. Gaddy's comments as well. And you have my written testimony, so I'll go in a little bit of a different direction than my written testimony. In 2008, there was a children's cabinet plan written by all of the secretaries from all of the child serving departments, and it established a desire to reduce the utilization of high-end congregate care facilities. And that was to be done in partnership with a growth of investments such as wraparound services, so and high fidelity wraparound in particular, which is an evidence-based model. So there were some initial investments, some initial efforts made there, and the reduction of the congregate care happened significantly so. I was at the department at that time, and I was a part of that. The challenge is that since the first few years when that wraparound was established, as Ms. Geddes just described, there have been continual disinvestments in the state's willingness to use any general funds whatsoever, to the point right around the same time as the Governor's Office for Children was eliminated, so was any state general funds to contribute towards the cause, to help serve those kids who might have private insurance or whatever the case may be. So now we have a situation where we have not enough providers participating because the rates are so low, and it's part of the reason we can't sustain our programming. So it's just important to note, if you're going to provide an evidence-based service, we need to fund it in full. There are expenses associated with scientifically proven methodologies, that require funding, and I urge support for Senate Bill 255. Thank you.
Good afternoon, Madam Chairperson, members of the committee. My name is Rob Bassler. I am with Arrow Child and Family Ministries. I'm also the public policy co-chair of the Maryland Association of Resources for Families and Youth. Arrow has been serving children in Maryland for about 30 years. We provide a range of services, including community mental health, and as well as qualified residential treatment programs. My colleagues have already talked about some of what the need is, how these gaps in services are impacting families. We as an agency are very eager to step in and support and fill those gaps, to the point where this year we became a licensed provider of family-centered treatment, which is a evidence-based intensive in-home therapy model that has several decades of evidence showing that it keeps families intact. We launched this year. We have been able to provide it both through some DHS funding for our qualified as aftercare for our qualified residential treatment programs, and in Harford County through a county grant. We have become providers through the 1915 I waiver to provide the service as well. Unfortunately, since getting that approval, we have not provided service to any families through the waiver. The reason we have not is that the reimbursement rate through the waiver only covers 2/3 of the cost of providing the service. And so as much as we want to expand beyond Harford County, expand beyond what we're doing now, this is not a mechanism to do it. There is only one other provider of the model in the state, but this model is also defined as the evidence-based practice for intensive in-home services. And so we urge you to give a favorable report to SB 255 as well.
Good afternoon, Chairwoman and committee members. My name is Lauren Grimes, here on behalf of the Community Behavioral Health Association of Maryland in strong support of SB 255. CBH represents 108 community-based mental health and substance use providers that serves the majority of adult and children accessing care through the public behavioral health system. I want to hone in specifically on a few things that others have touched on today. One, Maryland is no longer delivering high fidelity wraparound, but worse still, the department has made policy decisions that eliminate the possibility of combining even a standard array of services to wrap around a child. Care coordination, psychiatric rehabilitation, and respite, 3 services often used in combination to care for kids with the highest needs, can no longer be delivered together. Second, the confluence of underfunding and low utilization have devastated the 1915 I service. Some providers have, as you have heard, have closed their programs because the cost far exceeds reimbursement. Other providers, as you have also heard, deliver this evidence-based program funded by the 1915 I, but do so under a DHS contract. That service is reimbursed at a rate 33% higher than the Medicaid rate. What this means is that this provider can deliver services to children that are already in state custody and cannot deliver the services to children that are at risk from being removed from their home and having their family broken up. We are funding critical help too late. Thirdly, some of the children referred to the 1915 I are already on a wait list for residential treatment, meaning that the service is being offered to families when they may already be beyond the ability for it to help. I say again, help is arriving too late. A diversion program must be accessible to children and families before residential and inpatient levels of care are needed. This bill makes a significant first step in rebalancing behavioral health care for children in Maryland. I thank you for your time, and we urge a favorable report on SB 255.
Thank you very much. I think we heard from all of the sponsors panel, so we're going to go to Senator Bidle, then Ellis, then Reedy.
Thank you, Madam Chair. Senator Hester, thank you for the bill. And I know how important this is. I hear from my emergency room that we have children there maybe 10 days waiting to be moved to a facility. But I'm trying to figure out how this bill will keep that from happening. And the difference is, the health department has come out in opposition, saying that's $6.8 million. And your note doesn't particularly jive with that. So I guess I'm trying to figure out how it works and what the actual costs are.
Thank you for the question, Senator. In reverse order, and then I might punt to one of my experts to explain the technical details. There was an error in the drafting. And so that error that I mentioned on page 3, 24 through 26, that would expand the program to all children who are Medicaid eligible, not just the select few who are entitled under this program. And so once we delete those 3 lines, the fiscal note should come down substantially. I can't speak to what it would be cost wise, but we could try to estimate that and get back to you. And in terms of how this will make a difference, does anybody want to get into the specifics?
Sure, yeah. Other states that do have high fidelity wraparound have seen things like a 72% decline in costs associated with inpatient hospitalizations, a 43% drop in emergency room utilization. So when you provide these intensive in-home services before a child gets into crisis, and mobile crisis services is supposed to be part of the 1959, you can divert kids from those higher levels of care, and it's been shown to do that in other states.
Madam Chair, can I have one more question? Will this also apply to children that are in foster care? Because I understand that's also part of the problem.
Yeah, absolutely.
Thank you.
Senator Ellis.
Thank you, Madam Chair. Senator Hester, thank you for your leadership with this. I have a couple, I guess, technical questions, terminology. So everyone mentioned high fidelity wraparound services. So could you give me some examples of that, please?
So in my written testimony, I tried to spell out what is high fidelity wraparound. We've thrown that around and we don't really have time to define it anywhere. It is an evidence-based model of providing essentially intensive care coordination to a family. And it presupposes that the family and the child know best what they need to be successful in the community. So they pull together the child and family wraparound facilitator, and pulls in whoever might be having contact with that family, a special educator, extended family members, friends. If their child is involved with DJS, a DJS worker, and they get together and establish this plan of care, which is supposed to be flexible, individualized, regularly monitored, and then changed if it's not working. In order for plans to be individualized, there are things that a child may need that aren't in the Medicaid array of services, things like tutoring for a child who is struggling in school. That's where those customized goods and services dollars come in to be able to really make a plan of care individualized. And there are some Medicaid services that are written into a plan of care, but there may be other non-traditional services, martial arts therapy, whatever the child is determined the child needs to be successful in the home.
Yeah, thank you.
A very brief comment to that. Is that okay? Please, very brief, I promise. When a parent says no to taking their child home in an emergency room, that is not something that any parent wants to do. It's the result of them feeling absolutely desperate and nobody's really hearing what they need in order to take their child home. So the idea of wraparound is they're actually being heard.
Okay.
Right. Thank you.
Yeah, and that's an excellent explanation. Thank you for that. And so another term, I'm not sure if I heard it correctly, is it 1959 pros or 1950 I's? Could you?
1915 I.
191915 and the letter I as in India.
Yep.
So what is that program? 1915 I.
So that program was developed with a Medicaid state plan amendment to try to replace the high fidelity wraparound that Maryland had previously, that was being funded with state general funds and federal grant dollars. So it was supposed to be a replacement for high fidelity wraparound, but for all the reasons we've given you, it hasn't worked that way.
So the 1915 I replaced the high fidelity wraparound service program, which reduced the number of users of this basically needed service.
Higher level of services.
Higher level of services. Yeah. And that was the idea. What was the idea between for replacing the high fidelity with the 1915I? Is that to save money or?
So we can get Medicaid reimbursement for the services
Okay,
before it was being paid for with state general funds.
yeah. Okay. Well, thank you for your answers. Thank you, Madam Chair.
Thank you, Senator Reedy.
Thank you. And many people on our committee, and I would include myself because I haven't been on the committee that long. A lot of these issues we haven't heard as much about before. So I hope that the questions I'm going to ask are maybe a little more top level. I hope that's okay. So we definitely don't want the kids in the emergency room. It's a problem for sure. When we went away from high fidelity to 1915I, it was wanted to get Medicaid reimbursement. If I remember correctly, and feel free to correct me if I'm wrong, we were paying astronomical sums of money for 300 children. Correct? I remember a number being like millions and millions of dollars. It was like every child is important to us. And I'm not trying to put a dollar sign on it, but it is a factor that you're looking at cost benefit for what's most effective. So was that the case, or am I misremembering that?
I can't.
I'm not saying the current program is the right one. I'm just asking, was that why?
I don't,
I don't think any of us have specific figures on what, and it was a per person per month kind of rate. But I will say that where children are ending up now in hospitals, in residential placements is drastically more expensive than high fidelity rapid.
No argument. I'm not defending the current system. I'm trying to understand how we got where we are. Can I ask, and Lauren, Ms. Grimes, I wanted to ask you, because I was looking at everybody's testimony, I was reading yours. These children with intensive mental health needs, can I just understand, these are not children who have a mental disability, correct? Or are they? Are these disabled children? Or are these children who have a mental health crisis in their life?
I think they can be either or both. I think these are children that are often involved in multiple systems, DJS, child welfare, have touched the mental health system or the substance use system. They are not new to behavioral health care.
What does that mean when we talk about behavioral health? I know what behavioral health care is, but explain to me, like, for example, years ago, I knew someone who had adopted a child that had been born to a drug addicted mother, and they adopted, and he ended up having to be institutionalized. I'm not trying to get into specifics. Is that an example of the kind of people we're talking about, or is it, because that obviously was something beyond that young person's control, because their brain just was not formed enough they needed institutional support. Are we talking about those kind of children, or are we talking about something less than that as far as
Well, the requirement is that they have a DSM-5 diagnosis.
which is?
The diagnostic statistical manual diagnosis, a mental health diagnosis, so that they're required to have a mental health diagnosis that's listed in the DSM-5.
Okay.
And they have to meet other criteria as well. There is a CASI assessment, the Child and Adolescent Services Intensity Instrument, so they also have to be assessed again once they meet the diagnostic criteria and have a letter from a psychiatrist within the last 30 days saying they meet this medical necessity level of care. Then they again have to have an assessment done to make sure that they meet that acuity of need that's required to be in the 1915I.
Okay, and so right now, because that diagnosis, in your view, it's too tight, so it's not allowing enough kids to access the 1915I, or is it that it's just not effective?
Well, it's just not the eligibility criteria that becomes problematic is not just about a DSM diagnosis. That is one of many things.
Okay.
But eligibility criteria includes you have to have had 2 emergency room visits or a residential treatment placement already. And interestingly, we've been moving as a state towards encouraging families to call things like mobile crisis. And mobile crisis is not one of the things that qualifies you to access the 1915I. So no, these are not largely, to answer your question, Senator Reedy, children who have had a hard time once. These are children who have had significant mental health challenges and behavioral challenges in school, in the community, and need a kind of wraparound.
But for whatever reason, the program now, because there's not enough access to these kind of placements, because we don't have the funding mechanism, is a big part of this. In addition, because we went from treating 300 children Not that that would be the exact number, but we went from treating 300 children now to treating less than 30. But we're not suggesting that that 270 gap is they're doing fine. Obviously, they're still dealing. That's who's ending up in our hospitals. Basically, that's the gap. We're trying to figure out how to pay for that. Really, is what we're talking about. How to address that. And I'll leave that, Madam Chair. I know I think it's important because I just trying to understand. I was reading through what this evidence-based tool is, or what the wraparound service. But a lot of it sounds like family counseling, and it goes deeper than that. But that's a big part of it. And I'm trying to figure out, why is this so expensive? So I know we need to fix it. We need to fix it. So I'm just, if you want to conclude after all that, thank you.
I'll try to wrap it up in this, that right now we find ourselves, there's a lot of talk about needing to re-expand our residential treatment center environment, right? And had we not decimated the real high intensity community-based treatment over the past decade, we wouldn't be in that position. But that's where we find ourselves, is we're opening up psychiatric respite to get kids out of the hospitals, or expanding residential treatment because kids need it. We're not intervening early, and that's what we need to do.
Last question, Madam Chair. The old way that we decimated, in your words, was that getting children off of being on that list?
We at Catholic Charities reduced our residential capacity for youth from 190 to 75. And that was consistent with what was needed in the community.
Over the course of several years?
Over the course of about 7 years.
Okay, all right.
Yes.
I definitely want to work on this, so I'm just trying to understand it. Thank you very much, Madam Chair.
Thank you. I don't see additional questions for the sponsor of this panel. Thank you very much for your testimony. We do have some additional in-person and then some virtual witnesses on the bill. So we'll turn to Josh Howe, Lucine Parsley. I think those are the in-person witnesses. Good afternoon. You can take the microphone and proceed with your testimony.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Josh Howe with Compass Advocacy, here on behalf of the National Alliance on Mental Illness, or NAMI Maryland. NAMI Maryland is supportive of early intervention and coordinated wraparound services when it comes to children and youth that need these behavioral health services. The average delay between symptom onset of a mental health condition and treatment is up to 11 years. That means if someone is experiencing major depression of 14, they are unlikely to receive help until age 25. For many, that means the possibility of treatment comes far too late and at large expense. Senate Bill 255 expands access and reimbursement for services to children and youth that need it most by requiring the Maryland Department of Health to provide reimbursement for wraparound services delivered under the 1959 model established in the state plan amendment and COMAR. The bill would also require reimbursement for intensive in-home therapy delivered by providers using evidence-based practices under the model. Importantly, the bill would also require the Department of Health to expand utilization of the model to 100 children and youth who would otherwise not be eligible and are currently at risk of out-of-home placement. NAMI is also supportive of the coordination and reporting requirements outlined in Section 2 of the bill, which calls for the Department of Health, in consultation with stakeholders, to review eligibility requirements for provider reimbursement under the 1959 model and submit recommendations to the General Assembly. For these reasons, NAMI Maryland respectfully urges a favorable report on Senate Bill 255.
Madam Chair, members of the committee, my name is Lucienne Parsley. I'm litigation counsel at Disability Rights Maryland, which is the protection and advocacy center for the state of Maryland. And we're here today in support of Senate Bill 255. Disability Rights Maryland over the years has represented thousands of children with disabilities, developmental disabilities, mental health disabilities, behavioral disabilities, and co-occurring disabilities in special education and mental health matters. And for more than 20 years, we represented foster children in proceedings in juvenile court. As you've heard, all the evidence points to better outcomes when services are provided to children in their homes and communities. Further, state and federal law requires such services to be provided in the most integrated setting appropriate to the child's needs, which in many cases is the community. For too long, Maryland's been investing in institutional and out-of-home services for these children. And as you've heard, services are provided too late, and that's when children have to have out-of-home placements. We are beginning to see, my organization is beginning to see more and more children being sent out of state, again, to RTCs and facilities as far away as Utah and Florida. And we've heard from numerous families over the years who've waited in ERs and in overstay status. So that's when they're proposed for discharge, they're clinically ready for discharge to a less restrictive setting, but there's nowhere for them to go. They could have been stabilized and remained at home if services had been available either before this became a crisis or after the crisis had passed. So we believe that Senate Bill 255 will help shift that balance by providing increased reimbursement rates, fixing eligibility issues, and reinstating the wraparound care model. Such services can help prevent out-of-home placements and costly institutional care. Thank you.
Thank you. I don't see any questions, so thank you very much for your testimony. Have a good afternoon. We'll now turn to Bethany Dame. Good afternoon.
Good afternoon. I am the mom to 2 adopted mentally ill children in North Potomac, Maryland. My son, Sam, who's now 14, struggled with mental illness and physical and verbal aggression towards my husband and myself before the COVID-19 pandemic, but his symptoms only intensified during the course of 2020 to the point that he was in and out of a psychiatric hospital in Virginia and eventually placed in residential treatment for over 8 months in Virginia. Following discharge, we were very lucky that Sam immediately transitioned to the Shepherd Pratt Care and Connection short-term program. They provided in-home support for Sam, parent coaching, and care coordination that helped make his transition home as smooth as it could be. The Shepherd Pratt team worked really hard to get Sam into the Targeted Case Management Program, TCM, because they knew that we needed long-term support as a family, and they thought that that support could come from TCM. We thought we were very fortunate to get one of the 50 TCM slots for families with a child who is not Medicaid eligible, but what we thought was wrong. Since entering the TCM program, it feels like we've fallen off a cliff. My family has truly felt all alone with a child who still struggles with significant mental illness and aggression. I hope that none of you ever have to live in fear of your child hurting you or destroying your property. There were services and resources that we were told that we'd had access to as part of TCM, none of which have actually been provided. The director of our county's TCM program told us that we have a care coordinator as an ongoing resource. We haven't. I really can count on one hand the number of times over the past year that we've spoken to that care coordinator. They also told us that they provide in-home therapy and support, something that's incredibly essential to a kid like my son, and we haven't received that either. I urge you to support 255 and to help kids like my son.
Thank you very much, and thank you for sharing your experiences with us. I don't see any questions, so we'll now turn to Joseph Wilson. Good afternoon.
Good afternoon. Thank you for this opportunity to speak with you today. My name is Joseph Wilson. I'm the Senior Director of Mental Health Services at JESSA, a community mental health provider in Montgomery County. And I'll say I have submitted written testimony, but as one of the only, if not the only agency currently providing high fidelity wraparound in the state of Maryland, I might be uniquely qualified to answer some of the questions that have been asked previously. One of the reasons the 1959, or actually 3 reasons the 1959 waiver has not been successful is it removed 3 significantly important components to what the high fidelity wraparound program provided previously. One is local control and collaboration and incentives for local agencies to collaborate and blend their efforts in how to assist families and youth with intensive needs. It was replaced by confusing and sort of burdensome, if you will, bureaucracy of Medicaid and the 1959 waiver, which of course disincentivized a number of providers as well as agencies to partner and collaborate. The second is that we really lost the ability to have flexible dollars associated with when we identify a need that a family has, allocating resources and funds for that family to be able to access what they need. And lastly, the wraparound process is a high fidelity practice, something that's not part of the 1959, is really what makes the difference between target case management and high fidelity wraparound. I'll say I also happened to be the director at the time of the program, an agency that ran the Northwest Community, the case management entity when the state was providing that. And I'll tell you, in terms of data, there was a question about expense. For the last quarter that I had, which is an FY11, our expense per youth was $99 per day, compared to the time with a daily rate of around $300 to $400 a day in residential care. So it's not as expensive as other options, and we certainly urge you to support this bill and give it a favorable rating. Thank you.
Thank you. Questions for this witness? Senator Reedy.
Mr. Wilson, I wonder if you could just reach out to me later to discuss that further, what you've, I won't burden the committee with the time of another question, but I'd love to talk with you more about that, those issues. Thank you.
I'd be happy to.
Thank you, Madam Chair.
Thank you, Senator. All right, we'll turn to Celia Serkin. Good afternoon.
Good afternoon. I want to thank you so much for giving me this opportunity to speak. My name is Celia Serkin. I'm the Executive Director of the Montgomery County Federation of Families for Children's Mental Health, a family support organization providing family peer support to families in Montgomery County who have children, youth, or young adults with mental health, substance use, or co-occurring disorders. For over a decade and a half, Montgomery County has funded a wraparound program focused on fidelity. And for over 15 years, we have delivered family peer support to families receiving county WRAP funded services. We currently work with JESSA. Our staff work with JESSA's care coordinators in helping families receiving a wraparound. We urge you to support Senate Bill 255 because it will allow many families with children or youth with intensive and complex needs, including those at risk of out-of-home placement, to access high-fidelity wraparound, the gold standard evidence-based practice for care. As Joe had mentioned, prior to 2016, Maryland had a high-fidelity wraparound program that was readily available to children and families across the state of Maryland. There were over 300 to 400 children served per year, and the outcomes were very, very impressive. These positive outcomes were the direct result of delivering a high fidelity wraparound, which was well monitored and evaluated by the Institute for Innovation and Implementation, which at that point was at the University of Maryland. Research evinces that to get the desired outcome, wraparound must meet fidelity. In 2016, the administration dissolved high fidelity wraparound and implemented care coordination through targeted case management in 1959, which was inferior to what had been provided. There were only 10 to 40. Thank you. I urge you to support Senate Bill 255. Thank you again for the opportunity.
Thank you for your testimony. And certainly if you haven't already, you're welcome to, send us something in writing with the end of what you were communicating.
Yes, I did submit written testimony.
Perfect. Okay. I don't see any questions from the committee, so thank you so much for your testimony. And colleagues, that concludes the hearing on Senate Bill 255. We'll now turn to Senate Bill 370, Certified Nursing Assistants, Licensing Requirements, and Administrative Updates. Senator Beidel.
Thank you, Madam Chair. I do have a panel. This is my only bill with you today. So. Thank you. Thank you, Chairman and members of the Finance Committee. Thank you for hearing Senate Bill 370. For the record, I'm Pam Beidel, Anne Arundel County. Thank you for the opportunity to present Senate Bill 370, Certified Nursing Assistants, Licensing Requirements, and Administrative Updates. This bill seeks to address a critical issue that's been a theme for this legislative session, the healthcare worker shortage. In order to ensure that nursing homes can be appropriately and adequately staffed, we must eliminate any barriers. One such barrier is the ability or inability for nursing homes to employ certified nursing assistants known as CNAs. Nationally, CNAs can work in all settings. However, in Maryland, it's the only state that does not allow a CNA to work in a nursing home. Rather, to work in a nursing home, Maryland requires an individual to be a geriatric nursing assistant, which can be viewed as an add-on to the certification for a nursing assistant. If all other states allow CNAs to work in nursing homes, shouldn't Maryland? As a member of the Oversight Committee on Quality Care in Nursing Homes and Assisted Living, as well as the Commission to Study the Healthcare Workforce Crisis in Maryland, we have repeatedly heard the difficulties nursing homes experience hiring staff, ultimately forcing them to rely on more expensive nursing staffing agencies. This issue simply doesn't affect the nursing homes. It affects all other settings. For example, hospitals have reported that patients are staying in the hospitals longer because nursing homes cannot staff all their beds. This affects our ability to be successful in controlling costs under our all-payer waiver. And remember, we've heard how emergency rooms, emergency departments are so overburdened and they're taking so many hours to see patients. Part of it is we can't move our seniors from the hospital to nursing homes. Therefore, we can't move our patients from ED into the beds in the hospitals. And it's just this ongoing domino effect. So we really need to help our nursing homes get staffing. Senate Bill 370 makes the necessary changes to allow CNAs to work in nursing homes. It does not reduce training requirements for those working in nursing homes. Federal regulations require that those who work in nursing homes satisfy certain training requirements. In order to be approved as a CNA training program, a vendor must comply with these federal regulations. The emphasis in this bill is to remove administrative steps that accompany this additional designation. The hope for this bill is that it will create fluidity for the worker to be able to move between healthcare settings, increase the workforce that nursing homes can hire, and hopefully stop individuals from leaving Maryland to go to work in neighboring states. I respectfully request a favorable vote on Senate Bill 370.
Thank you very much, Madam Chair, well, she's not here, Madam Vice Chair, and members of the Senate Finance Committee. My name is Dana Kaufman. I'm here on behalf of Lifespan Network and the Maryland National Capital Home Care Association, as well as the Hospice and Palliative Care Network of Maryland. Senator Bidle did a very thorough job in explaining the bill and really what this bill is trying to address. So Lifespan Network, of course, is an association that represents nursing homes, but the reason that the Maryland National Capital Home Care Association and the Hospice and Palliative Care Network is also supportive is for the exact reasons that Senator Bidle referenced, that the ability to staff and hire affects the entire continuum of care. And right now, nursing homes perhaps have the greatest hiring challenges, which is caused also because of the need to have what we call the geriatric nursing assistants. And just to reiterate what Senator Bidle did say, so long ago, before my time down here, which feels like it was very, very long ago, the federal regulations by CMS required that nursing assistants in nursing homes meet certain requirements. When the other states were looking at that, they created a certification program that complied with those nursing assistant regulations for everyone. Maryland bifurcated it, and they created a separate program to meet those requirements. As the years have passed, it's my understanding that the training programs are the same and incorporate the federal requirements, but we still have some requirements that just GNAs have to meet. So we're really looking to untangle that so that we can have nursing assistants be hired in nursing homes and work across all settings. What we don't want, though, is to require our current certified nursing assistants to meet any additional requirements. This bill is about removing barriers, not increasing requirements. So we're happy to work with the Board of Nursing to address any of their concerns. So thank you.
Good afternoon, Madam Chairwoman and members of the committee. My name is Kevin Hefner. I am CEO of Lifespan Network. It's been my privilege to work with Dana Kaufman for these many years. This is my first time appearing in this capacity. Lifespan, as you may know, is the largest and most diverse senior care association in Maryland and is proud of its identity as not just the largest nursing home association, but also the largest assisted living provider association in Maryland with more than 340 institutional members, including nursing homes, assisted living facilities, retirement communities, adult daycare, home care, hospice, and even a few hospital members. They all have one thing in common. They all need qualified nursing assistants to be able to care for older adults. We moved to our current offices in Columbia 5 years ago, and as sometimes the case when you move, we found some old things. We found a member survey from 1989 that asked the proverbial question, what keeps you awake at night? And the answer in 1989 was staffing and workforce. So 34 years later, that has only been exacerbated by an aging population and COVID. Clearly, a robust workforce is critical not just to nursing homes, but the entire continuum of care. In fact, for the first time in our country's history, it's estimated by 2030, there will be more Americans over the age of 65 than under the age of 18. We have much work to do. To that end, I'm proud to say that Lifespan recently began enrollment into Maryland's first ever hybrid asynchronous CNA/GNA training program with all the course content online and only labs in person. As Dana said, it's all about removing barriers like transportation, childcare, work schedule. Our program does that, but we need help. We're working to fill classes, aggressively planning for promotion in high schools and urban centers, but we need others to help us to be successful. There are natural barriers that exist to getting into the field. It's physically difficult work, low compensation, but it's important that we remove the barriers that we can to help people to get into the field. Senate Bill 370 seeks to remove the certification barrier that currently exists, and we thank Senator Bidle for her efforts and urge a favorable vote.
Thank you. Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, Senator Bidle, for this bill. So I just want to get deep into the weeds as far as certified nursing assistant versus geriatric nursing assistant. So geriatric nursing assistant, do they require specialized training that's more coursework than certified nursing assistants? That's my first question.
Okay, so in Maryland, certified nursing assistants, if you look at it as being the basic level of certification, or what I would like to say almost is the umbrella. And then we have a geriatric nursing assistant add-on. Then there's a home aid. Last year, we got rid of the dialysis technician specification, and if there might be one more, but basically from what we can gather and what we understand, the Board of Nursing has to approve all the training courses. The training courses for the certified nursing assistants that are approved encompass the federal regulations that are particular to nursing homes. So it looks like there is one course. However, there is an additional exam that has to be taken if you want to then become a geriatric nursing assistant. And that classification allows you to work in all settings, but you have to be a GNA to work in a nursing home.
Okay, so thank you for that. So this bill gets rid of the geriatric nursing assistants, GNAs?
It gets rid of that distinction, which would allow then the nursing homes to be able to hire the certified nursing assistants. And again, we're not trying to diminish the training requirements, but all other states allow nursing homes to hire the CNAs.
Yeah, because you're saying the CNAs have the same training, same courses as the GNAs. And so
that is our understanding. And we are more than happy to work with the Board of Nursing on any amendments that would be necessary to try to decouple any additional requirements so that we can move forward with the premise of letting CNAs work in nursing homes.
Great, thank you. So if CNAs, certified nurse assistants, are able to work in nursing homes, then why would anyone take the geriatric test and do the additional training? Is that, so that's why the GNAs would disappear.
Yeah, well, they wouldn't have to. Yes, they would not have to take that additional step. That's what we're trying to make it more compatible across all settings.
Okay, great. Thank you. Thank you, Madam Chair.
Madam Chair, may I add, this morning I received a 6.5-page amendment. The bill is only 6 pages. So we will work with council and try to work through that amendment, but I haven't had a chance yet to do that. So thank you.
I just did. I was thinking it was a reprint or something. Okay,
Thank you.
thank you. I don't see any further questions for the sponsor panel. Thank you very much for your testimony. We'll call forward Aaron Greenfield and Dima Saloon. Good afternoon.
Good afternoon, Madam Chair, members of the committee. Aaron Greenfield here on behalf of Leading Age Maryland, a network of 140 nonprofit long-term care providers and senior housing operators. We are here favorable on Senate Bill 370 and thank Senator Bidel for her sponsorship. You have our written testimony. As you heard, this can be a complex issue, and Leading Age Maryland recommends that the Maryland Board of Nursing and other stakeholders are convened to fully evaluate the current CNA, GNA certification processes and to identify what changes would be necessary to reach the intent of the bill. At my request is Dima Salom, who is a master's in public health student at the Johns Hopkins University Bloomberg School of Public Health, who is completing a practicum with Leading Age Maryland. And this is her maiden voyage to testify before a standing committee. So if it's okay, Madam Chair, I turn it to her.
Thank you, Aaron. Thank you, Madam Chair and members of the committee. My name is Dima Saloom, and I am here today on behalf of Leading Age Maryland to request a favorable report of Senate Bill 370. In light of staffing shortages across the state exacerbated by the COVID-19 pandemic, nursing homes struggle to secure sufficient staff. To become a certified nursing assistant in most states, individuals complete a state-approved training program, a national and federally required examination, and a state-mandated certification exam. They are then allowed to work in most healthcare settings, including long-term care facilities and nursing homes. The state of Maryland, however, has a unique credentialing system that offers several levels of certification. Certified nursing assistant is regarded as an entry-level credential in Maryland. CNAs are only allowed to work in licensed nursing homes if they obtain additional geriatric nursing assistant certification, which is regarded as the equivalent of the CNA credential issued in most other states. Leading Age Maryland is invested in ensuring that professionals who are qualified to deliver care in places that most need it, like nursing homes, are allowed a facilitated opportunity to do so. If enacted, Senate Bill 370 would alter Maryland's credentialing system to resemble most other states. CNAs in Maryland could meet the federal requirements to work in comprehensive care facilities, and out-of-state CNAs would be qualified to work in Maryland nursing homes without the need for additional certification. Introducing such changes is likely to be a step forward in addressing the care team staffing shortages that long-term care facilities and nursing homes are suffering from. For these reasons, Leading Age Maryland respectfully requests a favorable report for Senate Bill 370. Thank you.
Thank you. Well done. I don't see any questions from the committee, so thank you for your testimony. We do have one virtual witness signed up, Jane Kriek.
That's great, Madam Chair. Jane Krinky.
Cranky. Thank you. Good afternoon.
Good afternoon. Thank you, Madam Chair and members of the committee. My name is Jane Krinky. I'm a legislative analyst at the Maryland Hospital Association, and we're testifying today in support of this bill on behalf of our 60-member hospitals and health systems. Maryland hospitals, as you know, are facing the most critical staffing shortage in recent memory. Our hospital data show nearly 1 in 5 nursing assistant positions are currently vacant. Over the past year, Maryland hospitals have worked together to address the high demand for CNAs by building an acute care CNA pathway. So this means that hospitals have established their own training programs based on curriculum approved by the Board of Nursing to upskill their employees who are interested in a clinical role within the hospital. There's been a lot of interest in these programs, so going from environmental services or dietary to a clinical role. So currently we're working with the Board of Nursing and Credentia, which is the company that administers the GNA exam, to create a standardized exam for these acute care CNA training programs. And we support Senate Bill 370 because it removes this distinction between CNAs and GNAs. And like you've heard previous people testify for, we think it'll really help our long-term care partners with their workforce struggles as well. The basic training curriculum that the board has approved includes the federal requirements, and the acute care CNA curriculum just adds on additional skills. So based on our review of the bill, we don't think it would require a graduate of an acute care CNA training program to take the national exam that GNAs are required to take. However, if this is the case, we do ask for consideration or an amendment. We think this would place an unnecessary burden on these graduates of these programs, especially if they're not looking to work in long-term care. In addition, the national test doesn't include some of the skills that you would learn through an acute care CNA training program, because again, there are additional skills. The statute broadly defines CNA, and so our hospitals rely on them greatly. And for that, we ask for a favorable report, just with consideration of the exam piece. Thank you so much for your time.
Thank you very much for your testimony. I don't see any questions from the committee, so that is all for this afternoon. Thank you very much, colleagues. That will conclude the hearing on Senate Bill 370. We'll now turn to Senate Bill 349, State Board of Examiners, Psychologists, License and Registration, Issuance and Renewals, Electronic Means. Senator Washington, good afternoon. If you have a panel, you can feel free to bring
Yes, so
anyone.
there's three. Yeah, very good. Thank you, Madam Chair. As I was sitting listening, I missed those bills, but when there's 100 of them, it's a little different. So, but I believe this is the right place. For the record, Senator Mary Washington, and I'm here to testify and ask for your favorable report of Senate Bill 349. It's a very straightforward piece of legislation asked to be submitted by the Board of Examiners. There's no opposition. And what it's doing is allowing the Board of Examiners of Psychologists to issue licenses electronically. Right now, 19 of our boards do this. And SB 329 specifically allows for the electronic issuance of licenses, as well as the creation of an online database of all the licenses with renewal dates for the convenience and use for both providers and clients. Now, this is a good thing overall because it's modernizing across a number of our fields. We're doing this with a number of our boards and our licensing. So of course it saves money, which is, a good thing. I know Senator Reedy likes that. And also it just improves the turnaround and the speed at which our professionals, our licensees can get their licenses. Now, I had some concerns, which you may have as well, and I just wanted to share my thoughts around them. At first, I was concerned about converting to online system for people who prefer paper. I mean, there are people who prefer paper. I still use my binders despite my staff wanting me to just have my iPad, but I like having the paper. So under section B2 of this bill, the licensees are able to request an official license and certification via mail. Additionally, the licenses will also receive a renewal notice via mail 90 days prior to the license expiration. Also, there's an opportunity for individuals to opt in to receiving mail. My second concern was always about privacy and data privacy when it comes to databases, and wanting to make sure that the individual psychologists personal information could remain safe. The bill addresses this by removing the requirement that's currently in law that a license display the full name and the personal information of the licensee or registrant online. So clients can look up their providers by the license number, and they can make sure that the individual is licensed without getting any other personal information. So I ask you for your favorable report of this bill. And I have 3 people who want to testify.
Good afternoon, Madam Chairperson and members of the committee. My name is Samantha Ruckert. I'm a psychologist in Maryland, and I am the current chair of the Maryland Board of Examiners of Psychologists. I'm testifying in support of SB 349. Our executive director, Lorraine Smith, was here, but was not feeling well and had to step out. So I will be essentially combining my testimony with hers, but mostly just reiterating what Senator Washington has already said. This bill permits those that hold an active license or registration to print verification of their status from the board's website instead of receiving a license in the mail. It will also allow the board to email renewal notices instead of mailing them. And again, just to reiterate, several boards have already moved to this type of a paperless platform. These changes will reduce the time that it takes to receive a license, expedite communications between the board and the licensees. The other benefits of the bill are, as I said, expedite communication, improve accuracy, and also provide a significant cost savings to the board. In special circumstances, when a licensee or a register is unable to print a verification of their license or registration, the board can print a paper copy of the license registration verification from its website and send it by first-class mail to the address on the application. So I'll just add that in my 15 years that I've been licensed as a psychologist, I've been getting one of these, this and this, and I've had it, but I've really never needed it. I've never had any difficulty just going on to that. We've had this platform for many years and just verifying that we are in fact licensed. So thank you for your time. The board respectfully asks that you support this bill.
Thank you. Any questions for the sponsor or this witness? See no questions. Thank you very much. We have one virtual witness on this bill, Mark Trulinger. Good afternoon.
Hello, good afternoon, Madam Chairwoman and members of the committee. Thank you very much for allowing me some time to speak. I'm here on behalf of the Maryland Psychological Association to say that we are in support of this bill and would like the committee to report favorably. Anything that helps to modernize the system and make things smoother is something that we support as we move forward. One thing that's important is as things are waiting to happen by paper, whichever direction it's going, it creates a situation of angst of whether or not these things have arrived. So being able to have all of that electronically is good. It also creates angst and uncomfortable situations if you don't know if it's arrived yet. You know, sometimes you're calling and then you're like, do I call again a couple of days later? You don't want to bother people either because they have a lot of work to do. So this bill is a good step towards, you know, making things more electronic, smoother, and, you know, very much more comfortable from our end of things. So we're very much in support of this bill, and I thank you very much again for the time that you've allotted.
Thank you. I don't see any questions, so thank you very much for your testimony. Have a good afternoon. That will conclude the hearing on Senate Bill 370. We'll now turn to Senate Bill 399, Health Occupations, Environmental Health Specialist Revisions. Senator Washington, and you can feel free to bring forward your panel again.
Thank you, Madam Chair. The record, Senator Mary Washington, asking for your favorable report of Senate Bill 399, Environmental Health Specialists. Now, this is a little different. There are components of the legislation that are straightforward, somewhat just updating of things. But over the last few days, it seems that it's growing in its mission. And so I will address first the parts of the bill that are fairly straightforward and similar to the last bill, and then also leave it to this committee and perhaps the House sponsor as to what the additional aspects of the bill does. So it seeks to, broadly, it seeks to do two things. One is to address some educational components and changing of scope. But then there's also an attempt in the bill to address workforce. And so looking to create some opportunities for apprenticeships, et cetera. But initially, many of you might not even know that there is a such thing as an environmental health specialist. They are a lesser known of our professionals within the health occupations, but they have a tremendous impact on public health. They specialize in conducting inspections and investigations, and they collect data and they analyze data to help make necessary decisions to ensure the compliance with federal, state, and local health and environmental laws, as well as our regulations. So the first component of the bill does the following. Currently, their license covers about 11 areas, and those areas range from manufacturing of and handling and prepping of food and milk, our water supply and treatment, wastewater treatment, management, vector control. I didn't know what vector control was, but now I know that basically it's mosquitoes, but to eradicate mammals and birds and insects and arthropods and pathogens. Okay. And also good old rodent control. They also look at air quality, noise control, product safety, sanitation, et cetera. The bill seeks to add related public health emergency preparedness. So, and the second part is to reduce the amount of hours that are required from 60 to 30 to have specifically science courses of chemical, physical, biological, and environmental sciences, and to reduce that from 60 to 30. However, to also require then that the board adopt regulations regarding what type of laboratory coursework the board deems is necessary to achieve the goal of a well-qualified environmental health specialist. Additionally, they want to set some requirements regarding the way in which the examination is administered, which actually I find interesting and good. Why I believe certainly these first components are really important and why I took the bill was that during our last, during the COVID pandemic, we absolutely addressed and we were not as prepared as we could have been, but we did have infrastructures to address the physical public health component. However, when it dealt more broadly with the systems that manage the transmission of pathogens and manage the transitions and response, we didn't have that. And the specialists that are most capable within our current repertoire of professions could be our healthcare specialists. So for that reason, I am asking for your favorable report on these initial components and to allow others to speak to some of the other components of the bill. Thank you, Madam Chair.
Madam Chair, members of the committee, my name is Matt Cummers, and I'm the board chair for the Maryland Board of Environmental Health Specialists. I'm here to talk a little bit about the board's perspective here. We've had a few amendments that we're going to propose to this bill, and specifically to one that relates to the definition of practice as an environmental health specialist. We have language in there that indicates aspects of public health emergency related to public health emergency preparedness. We found that working with our partners, the Maryland Department of the Environment, Maryland Department of Health, that was a too broad of a definition to include within the environmental health specialist practice, a definition. So we do plan to request that be stricken, and we're going to come back after we've worked with our partners to come with more clarifying language. We also are asking that the language for the apprenticeship, allowing for the apprenticeship with Morgan State University to proceed is involved in the bill as well. We've proposed those amendments, and we're hoping that the committee will support that as well. We have other, really important amendments in the bill we've been working on for years, but those are the real key aspects. So we urge a favorable report.
Thank you very much. We'll go Senator Mounts, then Senator Ellis.
I'm sorry, real quick, there's a lot of testimony on this bill. I want to make sure I understand what the bill does. I'm going through here, reading it. Just in a synopsis, can you summarize for me exactly what we're doing? I know we're reduced, I'll let you do that.
I'll speak to the portion of the bill that I received and that I'm was prepared to present. However, the board has additional components and amendments that they're asking this committee to add to the bill, and I'll have them address those. So first, they want to make it, they want to change the requirement that that in order to be licensed as an environmental health specialist, that you have 60 credits of science. That's very high. And so we're reducing it to 30 credits. However, the nature of their work does require testing and analysis. And so we are requesting that the board set standards of regulation that can assure us that they have those basic research understandings and an ability to analyze and collect data. So that's what, okay. Okay, so there's that. The bill wanted to somehow allow the health specialists, environmental health specialists, to have a role in responding to public health crisis and preparedness. It sounds like there's going to be some adjustment in the language about how that is actually articulated in the bill, which is forthcoming. And then finally, there is a, two more, that there is the wanting to approve how examinations are actually done. They want more control over that. And then something I neglected was adding this definition of malfeasance and misfeasance to the list of their code of ethics.
So the malfeasance and the misfeasance would apply to the actual conduct of the.
Right, that's their ethics.
inspection.
Exactly.
And the response to public health preparedness, that would be training for environmental health employees on how to do their job in a public health emergency, pretty much.
Correct. That was the original intent of including that within the scope of practice as an environmental health specialist, because during the pandemic and many other times, we were, rolled out as, emergency responders. Of course, we also respond to other types of emergencies as well, radioactive emergencies, involved with nuclear power plants, et cetera.
And that language is not currently in the bill, correct?
Well, it is. So the drafters suggested legislation that would achieve that goal. However, the board chair has received some information that language is too broad. And so we'll be bringing the committee something that's more specific to their profession.
Thank you. You've answered my questions. I appreciate it. Thank you.
Thank you. Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, Senator Washington, for this bill. And so in your testimony, I was listening closely to what you were saying. So in the list of, I think, nuisances you mentioned that environmental health professionals deal with, did I hear you correctly when you said birds?
Yes.
So, okay, that's, how would birds be a nuisance that you have to deal with? What do you do with birds? Because I know we have several bills over the past few years trying to protect birds. So when I hear them called nuisances, I'm like, okay, what's going on here?
You may or may not have heard of a disease called psittacosis, but that's one of the major diseases that we're looking to control, because it can actually the birds can be the vector for that disease, and it can spread to human beings. I mean, we hear this with chickens and so on and so forth. So that's one of the things we do, is we regulate pet stores, et cetera, to ensure that they're doing regular testing of their animals, that you know, to ensure that that disease isn't prevalent within their stock.
Yeah, so what's that disease name? Can you spell it for me, if you can?
Psittacosis.
Okay, great. Thanks with that. Okay, great. Thank you for that. So also, second part of my question, really quick. The environmental health specialists is that the same specialists that are in all the health departments in all the counties?
Correct.
And so how would this legislation affect their qualifications and the amount of environmental health specialists we have? Because they're very important for the counties, and they do a lot of work with septic systems and certification. So will this kind of help them do a better job in making sure, say, septic systems are well functioning? And because right now there is an issue with that not being regulated too well.
Exactly. So as most professions are experiencing right now, we have terrible workforce crisis. And so what we're trying to do with this, the board is actually trying to help bring in people into the fold in a couple of different ways to try to solve some of our workforce issues. One of the ways is that we're looking to improve the educational requirements. You can still right now get a license as an environmental health specialist with 30 credits of science. However, it takes you 2 years of training period to accomplish that licensure. What we're trying to do is reduce that down to 1 year. We want to open this up to as many professionals as we possibly can, and not narrow the scope the way it is currently. And we also want to provide the board flexibility to allow different types of lab courses as opposed to just science and chemistry. I mean, biology, chemistry, you know, historically approved courses. So it's going to help us open that pool of talent up for graduates of universities. It's going to help us bring those folks in easier, as well as the apprenticeship that's really crucial. That Morgan State apprenticeship that Dr. Mitchell is working on right now is probably the most exciting thing we've got going on in environmental health, because it's really going to create that pipeline for, you know, folks to actually study environmental health in college and then come right into the workforce.
Thank you very much. Appreciate it.
Yep.
Okay. Thank you.
Thank you. Don't see any questions from the committee. I just had one quick question, I guess, for the sponsor or your witness. I'm counting 3 favorable with amendment statements in the folder from different groups. So you said you're working with, I assume, all the stakeholders, because they're different sets of amendments that are offered by each group.
Right.
Yes. Yes. And also specifically, one of the things that I believe the component about the apprenticeship is actually can be accommodated in another committee, specifically in EEE, because we do have that. So that's part of the conversation, is that it might not be needed to be amended in this bill, and that it can stay in the frame of profession, licensure, and scope of practice. And then the other issue can be added as we're building out some other apprenticeship programs that we're currently working on.
Thank you, because I saw I think it's the health officers that said support as amended, but I didn't see which set of amendments they were supporting. So you may want to.
Yeah, they wrote a thesis, and it was, you know, they were correct in it, but I think it can go in another bill.
Okay, thank you. Thank you very much. Thanks for your testimony. We have some additional witnesses signed up on this bill. Don Curtain, Les Knapp, and Clifford Mitchell. Good afternoon. You can come on in and get started when you're ready.
Thank you, Madam Chair. I'm Don Curtian. I am the Director of Environmental Health for Anne Arundel County. I'm also here representing the Maryland Conference of Local Environmental Health Directors and the Maryland Association of Health Officers, who we support this Senate Bill 399 as amended. What Senate Bill 399 will provide is the Board of Environmental Health Specialists with the capability and flexibility to make decisions to qualify applicants to obtain their certificate of eligibility to work as an environmental health specialist. Most importantly, the bill will also provide the board the ability to recognize and approve the apprenticeship program that's currently being developed by the Maryland Department of Health and Morgan State University. This apprenticeship program will give students a direct pathway into the environmental health specialist career field, working under the supervision of a licensed environmental health specialist. This will be a valuable educational and training program to expand the number of environmental health specialists in the state and to assist in rectifying current workforce shortages. Currently, several local health departments have critical staffing shortages, and overall, the local health departments programs have a 40% vacancy rate. These positions are critical in the review and issuance of permits for wells, septic, swimming pools, food program, and specifically the review and approval of building permits. Expanding the number of environmental health specialists will increase efficiency and reduce backlogs in the impacted counties and shore up the workforce in the environmental health, local health programs, prepare for community growth. I'm requesting that you, as amended, support favorably this bill. I will also add that I've done this. I've worked at the Anne Arundel County Department of Health for 41 years. I cannot do this forever. So we need some more people to learn this so that they can take over.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I'm Clifford Mitchell, the Director of the Environmental Health Bureau at the Maryland Department of Health, and I really want to thank you. I want to thank the sponsor for this very important piece of legislation, which focuses on a critical and frankly, often invisible and underappreciated part of the public health workforce. I have remarks that are on a position that's already before you, including proposed amendments. But I just want to talk for a moment about the work that these folks do, because I want to agree with Senator Ellis and others that this is a part of the public health workforce that's responsible for some of the most important disease prevention, injury prevention work that happens in the state. And it's often very difficult to find people to do these jobs because they are not necessarily the jobs that people think of first. These are the folks who go in and do restaurant inspections, they do sewage treatment inspections, and without them, a lot of the disease fighting progress of the health department and the Department of the Environment would in fact not be able to operate. So we fully support and applaud the senator for this bill. We are very invested in improving the pipeline, as has been said. We are working with Morgan State University on an apprenticeship program, and we're very excited about the opportunity to do so in a way that will strengthen the diversity and the strength of the workforce for environmental health. And with that, I just want to thank the committee because this is, as I said, a part of the workforce that often gets neglected, but is really important to everybody who lives in Maryland.
Good afternoon, Chair Griffith, Vice Chair Klausmeier, members of the Finance Committee. I'm Les Knapp, Senior Local Advisor for the Maryland Department of the Environment, here testifying in support of Senate Bill 399 with amendments. I also would like to thank the bill sponsor, the Board of Environmental Health Specialists, and the other involved stakeholders for addressing this important issue. Both at the state and local levels, we are facing significant challenges in hiring and retaining environmental health specialists. And as was previously noted, one area that environmental health covers is well and septic permitting, which is within MDE. And in some jurisdictions, we're seeing staffing shortages so dire that residents and businesses are facing significant delays to permit requests, including those simply for needed repairs. Now, MDE is working on a long-term solution to this problem by addressing 4 key causal factors. Senate Bill 399 addresses one of the 4 factors, and that is the overly prescriptive education requirements. The bill would give the board more flexibility and discretion in evaluating and establishing educational criteria for both candidates and licensees. And this flexibility created by the bill is both needed and critical. Speaking on the amendments, MDE is extremely supportive of the proposed apprenticeship amendment that would run through Morgan State. And we would hope that that would be incorporated. It was also discussion of a second amendment that would strike language in the bill that included public health emergency preparedness as part of the practice of environmental health, being an environmental health specialist. And MDE is opposed to this provision as it would have unintentionally required numerous emergency and disaster responders to become licensed with the board. We do support the amendment that would strike that provision and are certainly willing to work with the parties to come up with more specific and nuanced language there. So in conclusion, again, we thank the sponsor, the advocates, and with the discussed amendments, we'd like a favorable with amendments. Thank you.
Thank you very much. I don't see any questions for this panel, so we thank you very much for your testimony and for your input. And I see the sponsor still here. It sounds like you have lots of conversations ahead. Thank you. All right. Well, that will conclude the hearing on Senate Bill 399. We're now going to turn, colleagues, to Senate Bill 213, Health Occupations, Clinical Nurse Specialist Prescribing. Senator Ellis, the first of three bills before us this afternoon. And I see your panel coming forward. So good afternoon to all of you. And if you could please introduce yourselves before you speak so we can keep track of who's here. All righty. Thanks so much.
Thank you, Madam Chair, Vice Chair, and members of the esteemed Finance Committee. I'm Senator Arthur Ellis from District 28, Charles County, here to present Senate Bill 213, Health Occupations, Clinical Nurse Specialists, and their prescribing authority. This bill would simply put clinical nurse specialists on an equal footing with all other advanced nurse practice nurses. And I'll tell you who they are a little bit later. They already have prescription authority. It would also add Maryland to the 39 other states and the District of Columbia where clinical nurse specialists are already authorized to prescribe. This bill means so much to me. My late mom was a nurse and she worked throughout the profession. And I know a little bit about the profession, but I have a panel of experts to tell you a lot because they know so much more than I do. But I've had a lot of conversations with members of this panel to get a deep dive in basically the duties of these four classes of advanced practice nurses, which are nurse practitioners. Then we have nurse midwives, nurse anesthetists, and I practice that one a lot. Hope I said it right. Is that good? And of course, our clinical nurse specialists, which we are addressing today as one of the advanced practice registered nurses. The clinical nurse specialists are experts in clinical practice, patient education, research, evidence-based practices, consultation, and have a role in the coordination of patient care, nursing, and healthcare systems. They provide clinical nurse specialists with prescribing authority, will expand access to care both in understaffed hospitals and rural areas lacking sufficient access to care. So a clinical nurse specialist frequently helps bridge the gaps in care, which includes making sure the patients have the appropriate medications. You know, this system is so spread really thinly that sometimes someone goes to a doctor with a particular issue and the doctor don't have time to really look at all the basic conditions that this patient have. Clinical nurses does that. They spend the time to really understand all the aspects patients is dealing with their health. Their focus on patient outcomes can assure successful transition out of acute health situations and decrease the chance of recurrence, thus saving patients, hospitals, and communities not just money, but also a sense of being cared for. With this bill, I'm asking you to allow clinical nurse specialists to be able to practice here in Maryland to the full extent of their education and training. Senate Bill 213 was introduced last year as Senate Bill 513, which passed the full Senate and went over to the House and probably just ran out of time. I'm confident the House will pass the bill this year, and I would love for this chamber to also do the same. So all that being said, I want to thank you for your consideration of Senate Bill 213 and respectfully request a favorable report.
Who would like to go next? Okay, and your name is?
Pamela Moss. So thank you, Senator Ellis, for your generous sponsorship, and thank you, Chair Griff, Vice Chair Klausmeyer, and committee members for allowing time to hear our testimony in support of SB 213. I'm Pamela Moss, and I'm a clinical nurse specialist in cardiac surgery and critical care with 13 years of experience as a nurse and 7 as a CNS. I'm the current president of the Chesapeake Bay affiliate of the National Association of Clinical Nurse Specialists and have volunteered on several national level committees to update specialty certification exam standards and maintain current scope and standards for CNS practice across the U.S. The CNS is one of the 4 advanced practice nurse roles and has been part of the U.S. healthcare system for more than 60 years. Providing clinical expertise to a complex specialty population throughout the continuum of care is at the very foundation of our CNS role. Everything we do stems from our ability to provide direct patient care. But a CNS approaches patient care in a holistic manner that enables us to address the quality of patient care, mentor nursing staff at bedside, and work within interdisciplinary teams to promote and drive evidence and research-based care that provides safe, low-cost, optimal patient outcomes. We are all educated at the graduate level and have completed training in advanced physiology, pharmacology, and physical assessment in addition to our area of specialty. 40 states and the U.S. Department of Veteran Affairs have granted CNS's prescriptive authority. Prescribing is complex, but it involves so much more than just ordering medications. Prescriptive authority would allow the CNS to follow through on their patient care plans, order patient referrals, lab work, diagnostic tests, and even specialty equipment like a walker, wheelchair, or wound care supplies, allowing us to promote quality of care for even the most vulnerable and complex patients. As a CNS, being able to prescribe is part of my training and well within my ability. However, without legislative approval, without your approval, my ability to practice at the full scope of my education and practice is hindered, limiting the care that I can provide for the community that surrounds me. I would ask this committee for a favorable report on SB 213 and grant Maryland CNS's prescriptive authority. Thank you.
Okay, thank you very much. And who would like to go next? Okay.
Good afternoon. My name is Paul Thurman. I'm an assistant professor at the University of Maryland School of Nursing in the acute care nurse practitioner and clinical nurse specialist program. I'm also a graduate of the program in 2007 when it was a master's program. It's now a Doctor of Nursing practice degree. I've practiced as a clinical nurse specialist since 2007 to 2019 at the Artemis Cali Shock Trauma Center. I'd like to talk to you about the educational requirements that clinical nurse specialists and nurse practitioners complete. As Pam said, the core elements of the advanced practice nurse is physical assessment, pathophysiology, and pharmacology across the lifespan. These courses comprise the 3 Ps and their national requirements. Additional course requirements to support clinical nurse specialist practice in healthcare environments include research, evidence-based practice, information and technology systems, health promotion within populations, diagnosis and management courses, and each role completes more than 500 clinical hours that are supervised. So the University of Maryland School of Nursing, Adult Gerontology Acute Care Nurse Practitioner and Adult Gerontology Clinical Nurse Specialist Program plan of study has been included in your written testimony. I've also included the programs for Johns Hopkins University, their Clinical Nurse Specialist Program and their Nurse Practitioner Program. And I've also included a plan of study for the University of Oklahoma, because that state has prescriptive authority for their clinical nurse specialists. And if you look at them, they all have the same requirements. Each role has the same requirements. So while the educational requirements are equivalent, thank you.
Okay, and your name?
Samantha Young.
What is it?
Samantha Young.
Okay, thank you, Samantha.
Thank you, Senator Ellis, for sponsoring this bill, and thank you, Madam Chairs and committee members, for allowing time to hear my testimony in support of State Bill 213, Clinical Nurse Specialist Prescribing. My name is Samantha Young, and I'm a nationally certified and Maryland licensed clinical nurse specialist and nurse practitioner. I function in my roles as a CNS and an NP on different days of the week because these roles may be similar, but they're very unique in practice. As an NP, I manage a specific cohort of patients by prescribing medications and tests, performing physical exams, and completing patient education. When working in my role as a CNS, I oversee an intensive care unit to provide safe, effective, and efficient patient care. I am the clinical expert on best practice. I consult with the healthcare team, and I'm a resource to answer both clinical and policy questions as they relate to nursing practice, patient safety, and patient outcomes. My CNS expertise, skills, and education prepares me to assess individual patients or specified groups and identify gaps in healthcare delivery. A barrier to me providing comprehensive care in the current Maryland law does not allow me the ability to prescribe medications and durable medical equipment. I assess patients, identify needs for maybe wound care, physical therapy, or maybe even a specialized bed to prevent bed sores. Yet I cannot prescribe these treatments. I must interrupt a physician or an NP to co-sign my order, taking them away from their patients to sign an order that I have the education and expertise, but under current Maryland law cannot order. The CNS is not a duplicate role to the other advanced practice roles. Our foundational education is the same, but each advanced practice role provides a unique expertise to the practice of nursing. I ask you to vote favorably as I support this bill, and I hope that you do too, for State Bill 213.
Thank you very much. And
Madam Vice Chair and members of the Finance Committee, I thank you very much for having us here today. Senator Ellis, I think you took my testimony, but I'll try to make up for it. For the past 25 years, I have provided
your
health.
name?
Pardon?
what is your name?
I'm sorry. My name is Susan Deline Bodkin.
Okay, you don't have.
I'm
to
a
be sorry,
certified
but
nurse
that's okay.
practitioner. Okay.
I have to keep myself on track here, or I'll
Okay.
get a demerit, so.
We wouldn't want that to happen.
No.
For the past 25 years, I have provided primary health care for the citizens of Maryland's fabulous Eastern Shore. I'm a family nurse practitioner and provide care for patients from 10 to 101. I'm a member of the Maryland Academy of Advanced Practice Clinicians, previously on their board and co-chair of their legislative committee. In my spare time, I serve on the Talbot County Board of Education, immediate past president, and I'm on the Board of Appeals in Oxford. So I bring a broad perspective to the committee today. At this time, I have 2,000 patients plus at least 200 people on the waiting list, most of whom are from Senator Mout's and Senator Hershey's districts. We have very busy days, which are a blend of in-person and virtual healthcare visits. We deal with the usual sore throats, congested heart failure, diabetes, sprains, strains, etc. More and more, we have mental health problems. I would say 60% of our patients come to us with an underlying mental health condition. I love what I do, but it's getting harder and harder to provide the high quality of service that we are known for. We need help, and that help should come from clinical nurse specialists who are already trained and just need this one extra step of being able to prescribe. In the past 3 years, as you all know, our region and the whole state has lost primary care and other providers. Doctors and nurses are leaving the industry, retiring early, moving to other states. We have fewer and fewer specialists available for timely referral and a huge need for clinical specialists who can treat and prescribe. I beg you for the state health and well-being to support Senate Bill 213. Thank you.
Thank you, Susan. Okay, Mary Ann.
Yes, good afternoon, and thank you, Madam Vice Chair, Senator Ellis, and members of the committee. My name is Mary Ann Hiles. I'm a perinatal clinical nurse specialist. As a perinatal CNS, I care for pregnant and postpartum patients and their newborns, with a particular interest in patients impacted by opioid use disorder and neonatal abstinence syndrome. Pregnancy is a critical time point in a woman's life. Pregnant patients do not wake up and decide they're going to use drugs. However, patients with opioid use disorder become pregnant. This chronic relapsing disease impacts not only the woman, but her newborn. Patients with opioid use disorder are often motivated to change during pregnancy, but we need more providers to help them. While providers in Maryland who can prescribe buprenorphine are increasing, most providers are not educated in the specific need of pregnant patients, and especially the impact of neonatal abstinence syndrome on the newborn. Our wonderful OB providers are experts in the care of pregnant and postpartum patients, but often not in the treatment of opioid use disorder. As a CNS, I am the one to advise our OB providers on the proper care and medications to support our pregnant and postpartum patients while they are in the hospital. It has been my job to develop policies and order sets procedures for pregnant patients with opioid use disorder while they're in the birthing unit and throughout their postpartum stay. Overdoses continue to be the #1 cause of pregnancy-associated deaths in Maryland. It is evident there's a gap in care in both the hospital and the community. Federally, the Support Act of 2018 granted CNSs the ability to prescribe buprenorphine, but in the state of Maryland, I cannot without prescriptive authority. One of the main reasons I became a CNS was to improve outcomes for women and newborns impacted by this chronic relapsing disease. Integrating opioid use disorder into provider practices is much needed in our communities, but there is still a gap in the care of pregnant patients. Having prescriptive authority would fill this gap by allowing me and other CNSs to prescribe. Thank you for your time, and I ask you to favorably vote for Senate Bill 213.
Thank you. Are there any questions from the committee? Seeing none, I guess we'll go. We have a few more folks that have signed up favorable. And not any but one unfavorable. So we have Shirley DeVaris, Michael Patty, Nova Costin, and Tammy Breshenham. And I've been waiting to see Shirley DeVaris for a while now.
Yes, it's been a while.
Go way back, that's for sure.
It does. Good afternoon, Madam Vice Chair, members of the committee, and thank you, Senator Ellis, for sponsoring this bill. I am Shirley DeVaris, and I'm offering testimony in support of this bill and based on my 19 years of experience with regulating nursing practice. First as staff for the former House Environmental Matters Committee, and then as Director of Legislative Affairs for the Board of Nursing until I retired in 2019. In 2010, the Institute of Medicine published their landmark report on the future of nursing. A key recommendation of that report was to remove legislative and regulatory barriers for advanced practice registered nurses to allow them to practice the full extent of their education and training. Every subsequent report from the Institute of Medicine has included the same recommendation. The 39 states in the District of Columbia, as Senator Ellis stated, have given authority to clinical nurse specialists to prescribe. Not one of those states has ever revoked that authority. We have 310 CNSs in Maryland, and most work in underserved areas. 25.5% of them work in rural settings. 188 of them are nurse psychotherapists who cannot prescribe. They're certified and they are trained to fulfill a treatment program. Maryland has regulated nurse psychotherapists since 1990. As part of those regulations since 1990, they've been able to use pharmacologics in their practice, but they can't prescribe them. So they have to send their patients elsewhere to get a prescription for the medications they need. The same thing applies to our other clinical nurse specialists who are also adversely impacted by not being able to order equipment, supplies, medications for their patients. I'm asking you for your support on this bill.
Thank you very much. Tammy.
Good afternoon, Madam Chair and members of the Finance Committee. I'm Tammy Bresnahan. I'm the Director of Advocacy for AARP Maryland. And I can't say any more than what Senator Ellis and the rest of the panel said. But what I did want you to know is that AARP feels very strongly about nurses. We're so strongly about nurses that we have developed what they call the Center on Nursing at our AARP National Office in DC. And we have a whole team of people that do nothing but nurse research, and we work very closely with nurses across the country. And we wholeheartedly support expanding the ability for clinical nurses to be able to prescribe drugs. We think, one part of my testimony, and you have that, says nurses do remarkable things for people they serve. For many family caregivers, nurses are lifesavers, providing care for their older loved ones at home, often after hospitalization or while treating a serious medical condition. They're one of many reasons why Marylanders and Americans are able to continue to live at home where they want to be, and not in costly institutions such as nursing homes. So we ask you for a favorable report on Senate Bill 213. Thank you.
Okay. Thank you very much.
Great.
Michael.
Thank you, Madam Chair. Michael Patty here today in support of Senate Bill 213 for the Maryland Nurses Association and the Maryland affiliate of American College of Nurse Midwives. And we've heard from a lot of folks, so me too.
That was great testimony.
Thank you.
Yes, perfect. Is Nova Costin not here? Okay, all right, we have one more and it's Deborah Bricado.
Good afternoon, members of the committee. My name is Deborah Bricado. I'm from Maryland Right to Life. And on behalf of our over 200,000 followers across the state, we do respectfully object to Senate Bill 213. The 2022 session of the Maryland General Assembly significantly lowered the standard of care for women and girls with the Abortion Care Access Act, removing the physician requirement for medical and surgical abortions. This bill further erodes the standard of medical care for all Marylanders by allowing another health occupation to prescribe medications, including the lethal chemical abortion drugs. Maryland Right to Life is very concerned about the blurring of the lines between healthcare occupations and the easy availability to lethal abortion drugs, especially through telehealth. While all healthcare occupations have value for the delivery of healthcare, they are not interchangeable. The courses of study are not interchangeable. Broadening the scope of practice for health occupations places profits over patients. Maryland Right to Life opposes the introduction or passage of any bill expanding the scope of practice of any healthcare professional without language excluding abortion. Medical and surgical abortions carry serious risk of injury up to and including death. More prescribers does not equate to better health care. More prescribers of the abortion pill is not good for women and girls. Abortion advocates claim that they want abortion safe, legal, and rare. Well, abortion is legal, but it's not rare, and it's certainly not safe, especially with the advent of the abortion pill. The abortion industry itself has referred to the use of abortion pills as do-it-yourself abortions. Chemical abortions are 4 times more dangerous than surgical abortions, presenting a high risk of hemorrhaging, infection, and even death. A 2009 study in obstetrics and gynecology found a complication rate of approximately 20% for the abortion drugs, compared to 5.6% for surgical abortions. In addition to the physical harm, I urge you to consider the psychological harm of women and girls giving birth to their babies in a toilet. And then if they end up hemorrhaging, they need to get to the ER. So we urge you to protect the medical care of women and girls in Maryland and give an unfavorable report to Senate Bill 213. Thank you very much.
Are there any questions for Ms. Bricado? Okay, thank you. That ends Senate Bill 213. And now we will have Senator Ellis with Senate Bill 215. And would you like to bring your panel up? Thank you all.
Perfect.
Else, because I have a lot here, but
Okay.
okay, we'll
Yeah.
go with this panel and.
Okay. Thank you, Madam Vice Chair Klausmeyer, members of the Finance Committee. For the record, Senator Arthur Ellis from District 28, Charles County. I'm here to present Senate Bill 215, which talks about massage therapy, discipline, and definition. The purpose of this bill is to alter the definition of practice of massage therapy for purposes of the Maryland Massage Therapy Act to include the professional practice of massage therapy without compensation and alter the grounds for discipline massage therapists and procedures related to the discipline of massage therapists, including an appeals procedure and reinstating massage therapists who somehow have their license suspended or temporarily held. So I just want to get into the bill and go over 4 key parts of the bill. The Massage Therapy Board may deny a license or registration to an applicant who failed to comply with a board order. Obviously, currently, they don't have to comply. So this bill will give some teeth to the board, additional teeth. Also, an order by the board may not be stayed pending judicial review. This bill will allow that. And we went through this particular topic, previous bill, and of course we can constitutionally put that in this bill. Also, Senate Bill 215 would say that if a license or registration has been suspended or revoked under this bill, the Board of Massage Therapy may reinstate that license or registration only in accordance with the terms and conditions of the order of suspension, in order of revocation, or an order of reinstatement issued by the board. So basically, the board will remain the authority in the terms of licensure for all the members. So, Madam Chair Griffith and Vice Chair Klausmeyer, thank you for the opportunity to present Senate Bill 215 and ask for a favorable report. I now turn the mic over to my distinguished board.
Good afternoon, and thank you, Senator Ellis, for sponsoring this bill, Madam Chair, and members of the Finance Committee. Good afternoon, good evening. I'm Sharon Oliver, and I'm the Executive Director for the Massage Therapy Board. We appreciate the opportunity to testify in support of Senate Bill 215, as this is a bill that furthers the mission of the board and this body to protect the safety, health, public health, and well-being of the citizens of Maryland. There are several components to the bill, and I will speak on 2 of them. As Senator Ellis mentioned, the first provision that I'll discuss is prohibiting the stay of a final order revoking or suspending the license of an individual for egregious acts or blatant violation of a board statute or regulation. The board is very serious about protecting the public, and it is imperative that its order is never stayed, especially when an individual has committed an egregious act, has appealed their board order, and wants to continue practicing massage therapy during that appeals process. As recently as last year, we had an individual that was suspended for serious professional boundaries violation and wanted to continue to practice massage therapy. A second element of this bill, as Senator Ellis says, gives the board the authority to impose additional sanctions when individuals do not comply with a board order. Board's orders are serious. They protect the public. We monitor individuals, and we want to ensure that if they do not comply, then the board has additional measures to protect the public. For this reason, I'm asking for your support and a favorable vote on this bill. Thank you.
Hello, Madam Chair, members of the Finance Committee. Thank you so much. My name is Kirsta Bodnerchuk. I am the chair of the Board of Massage Therapy Examiners. I'm a licensed massage therapist as well as a small business owner. Thank you for allowing me the opportunity to testify in support of Bill 215. This bill includes a goodwill provision that clearly defines a pathway to re-entry into the workforce after discipline. The board recognizes that individuals can be rehabilitated and returned to the workforce as productive citizens.
This bill also closes a loophole to include oversight of individuals who practice massage therapy without a license. The definition of practice massage therapy was changed to with or without compensation. This broadens the protection to the public. And finally, we ask that the law requiring publication of board disciplinary orders in the Maryland Register be repealed. This is an archaic provision of the law, as most members of the public do not read the Maryland Register. The board publishes disciplinary orders on its website and reports each action to the National Practitioners Databank, a repository available to all state licensing boards and credentialing agencies. Publication in the Maryland Register is duplicative at best and a less effective mean to ensure that the public is aware of the board's orders. For these reasons, we ask for a favorable report on Senate Bill 215. Thank you.
Madam Chair, esteemed members of the Finance Committee, my name is Paula Jalanes. I'm a board certified licensed massage therapist, and I'm the vice chair of the Massage Therapy Board. Thank you for the opportunity to speak in support of Bill 215. As a member of the board, we take very seriously our role to protect the public. When we have a hearing with a therapist after receiving a complaint, our decision to suspend or revoke is decided after a thorough process of investigating the complaint, of listening to testimony, of questioning the therapist, and having separate board discussions. To grant a stay of the board's order while the individual is in the appeal process would reduce the public protection by allowing that individual to continue to continue to process. For that reason, requesting support of Bill 215.
Okay, Senator Lamb has a question.
All right, thank you, Madam Chair, and thank you to the panel there. I am, understanding of the need for enforcement. I think I just want to focus on one provision, which is right at the top of the bill, and I think you touched on this too, is on page 2, where it says that this could apply to someone providing massage therapy or massages with or without compensation. And I guess, my concern here is that you could have folks that potentially are, partners or girlfriends, boyfriends, giving a massage to someone else, uncompensated, of course, unlicensed, and that they would be under risk of being charged with a misdemeanor for practicing massage therapy without a license. How do you address that concern?
So the intent of changing the verbiage in this is to really go after a lot of the illicit industry. It's those individuals who are practicing without a license, who are putting themselves off as a massage therapist, but then they don't actually have any exchange of funds. So, and in that regard, they would say, I'm not practicing because I didn't get any financial compensation.
And the bill currently the statute currently offers exceptions for family members.
Yes.
True,
And
but a
students.
girlfriend, boyfriend, or someone who's otherwise, if I decide to give one of the other colleagues on this committee a massage, just because someone's had a long day, theoretically, I could be charged with a misdemeanor. And I recognize the intent. I certainly appreciate the intent.
Yeah.
I think the key part here is that someone engaging in this, even without compensation, could be caught inadvertently in this language.
Except there is a section within our current statute that does state, working on family members or friends, that's
I don't think it captures friends.
Or
I think it only addresses
family members and other students.
Senator Lamb, if I am understanding you correctly, you're asking if a licensed person performs massage without compensation?
No,
or
an
is it
unlicensed.
an unlicensed individual without compensation. Well, part of what drove the need for this amendment in our statute is we've had individuals who are licensed in another state come across the line. And give you an example, there is a party and they are performing massages, and they say, well, you have no jurisdiction over us because I was not charging anyone, and it's not family and friends. It's someone that came across state line. And the board has no jurisdiction over that individual.
So, I've looked at other parts of the statute, and there are parts of the statute that govern alcohol and drug counseling, marriage and family therapy, art therapy, and clinical professional counseling that only govern compensated practice. I would like to hear if you've reached out to some of these other boards or practices to see how they enforce their parts of the statute, because it's similar in a way. If it's art therapy, our intention is not to snag people that are just working with kids to, feel better about themselves and expressing themselves through art, right? And I think that's the intention here too, is to not capture those folks. But I'm just concerned that without a provision for things like friends, and I consider Senator Kramer a friend, if I were to go over there and give him a back rub, that it would not be, that it might not be considered, it wouldn't be considered massage therapy, and I could be charged with a misdemeanor for granting Senator Kramer that relief.
I also don't think he would report you to the board for us to investigate.
But under this
But yes,
definition,
I
it would be
understand.
uncompensated massage to a friend.
We look into that.
Yes.
Okay. Would
I appreciate that.
would ask you to consider some of
Mhm.
these exceptions there to just make sure that it's not inadvertently
Sure.
touching on folks that, I guess no pun intended, it's not capturing folks that weren't intended as part of the language change for the compensation.
And that is something we can address in regulations as well.
But if you put without compensation into the statute, it kind of binds your hands in some ways with what you can do in regs.
Okay.
Yeah, and Senator, I think we can address that, and I'll follow up to get an appropriate amendment, working with the board to address your concerns.
Okay, I think nursing has an exemption for like gratuitous care for friends, domestic partners, and other family members. So
Thank you
something
for
to look
that.
into.
Thank you. Senator Kramer.
Thank you, Madam Chair, and I do want to thank the good Senator Lamb. It is Valentine's Day, so. But going beyond, I following up on his question, and maybe I missed this. Why would somebody come across state lines to a party and give massages uncompensated?
We've had people who have disclosed to us that they have done that. They are friends, they come to visit, they attend an event or something, and they give massages.
And should that be regulated in other? I can understand that you're very focused on the compensated side of the industry, which is, I think, where Senator Lamb was sort of looking for clarification. What I guess I'm missing is, why would someone put themselves out there as a professional and not be compensated for what they're doing? I can, look, if it's a bunch of friends getting together and maybe somebody is giving everybody massages and they've come over from out of state, and even if they were licensed in Pennsylvania and they go, hey, look, I know how to give one heck of a massage, but if they're not compensated, why would it draw the attraction of the board?
We have had individuals who have done massages and have said to the board, because I did not, and we have had complaints, because I did not charge anyone, I was not performing massage, and the statute says in order for the board to have jurisdiction over this person, the person would have had to charge.
But why do you want, I guess what I'm trying to get is, why do you want authority over to somebody who's just giving a massage, but is not holding themselves out as a professional and collecting compensation for what it is the massage they're performing?
I understand what you're saying. And if we receive a complaint that individual injured or inappropriately touched, crossed boundaries, we have no jurisdiction.
But again, that just becomes a physical assault. If, in other words, going back to the example given by the good senator, if he were to cross those boundaries, then I certainly could avail myself of the courts and the criminal system in addressing that. I'm just, I guess I'm missing the point of why you're looking to go after folks that are not being compensated just because they gave a massage.
Yeah, Senator, could I just jump in there?
Sure.
I was working my brain, thinking about an example of someone who could come into the state or come into an organization and provide massages for no charge. So as a parent, I was a member of president of a parent association at a local college. And I remember we have what you call stress busters, where right before midterm and finals, the parent association have just a de-stressor party for the students. And I remember a couple times we've had massages volunteered from qualified folks, but who were out of state, and they didn't charge for it, but they actually came with their tables and
sounds like a nice thing that people were doing out of the kindness of their
yes,
hearts.
exactly. And so that's a possibility of a free service being provided from folks who are maybe in the industry, outside of the industry, but come in, provided at no charge to the folks.
Yeah, and then the board gets a complaint about a massage therapist performing massages for individuals, and there is nothing we can do. We can't even initiate an investigation to determine whether or not.
I think there's a little bit of a disconnect there between what I would think your goal is and your intentions, and maybe just, going a little bit beyond that. So, but thank you. No, I appreciate it. Thank you, Madam Chair.
Thank you. I see no additional questions for this panel or the sponsor, so thank you very much for your testimony. We do have 2 additional witnesses signed up in favor of the bill, Sabrina Lopez and Nova Costin. I don't see her here, so. Oh, Ms. Lopez, you can come forward. Good afternoon.
Good afternoon, Madam Chairman, Vice Chair, members of the committee. Thank you for hearing our testimony on SB 215. My name is Sabrina Lopez. I'm currently serving as the Government Relations Chair for the American Massage Therapy Association Maryland chapter. I am also a small business owner with locations in Anne Arundel County and Baltimore City. This bill is essentially designed to help protect the public from unlicensed individuals performing massage therapy and illicit activities that happen under the guise of massage therapy. There was a study done in 2004 on adverse effects of massage and whether or not the consumers could tell the difference between a trained individual and an untrained individual. That study determined that the person on the table was not able to tell if their therapist had been properly trained or not. So the adverse effects can cause more harm than good to consumers of massage therapy if they are getting massage from someone who has not been properly trained. So I ask you to give a favorable report on SB 215 to help protect the public from unlicensed therapists. Thank you.
Thank you. Are there any questions? Okay, thank you very much for your testimony. And colleagues, that concludes the hearing on Senate Bill 215. We'll now turn to Senate Bill 216, our final bill of the day, massage therapy definition and reimbursement. Senator Ellis and panel. Same panel. Excellent. Makes it easy. All right, good afternoon.
Good afternoon, Madam Chair, Vice Chair, members of the Finance Committee. Arthur L. Senator from District 28, presenting Senate Bill 216, massage therapy definition and reimbursement. And the purpose of this bill is simply to take out a provision in the law that says that a nonprofit health insurance plan, insurer, or health maintenance organization, or person acting as third-party administrator to reimburse a licensed massage therapist or registered massage practitioner for any services. So that's being taken out. And I just want to, in the interest of time, I ask for a favorable report on Senate Bill 216 and pass testimony on to the student chair.
Good afternoon again, Madam Chair, esteemed members of the Finance Committee. My name again is Paula Jalanis. I'm a board certified licensed massage therapist, and I'm the vice chair of the Board of Massage Therapy Examiners. Thank you for the opportunity to testify in support of Senate Bill 216, a bill that seeks greater protection of the public health, safety, and well-being of the citizens of Maryland. It also furthers the mission of our board and this body. In the bill under consideration today, we are seeking to remove exclusionary language that specifically precludes treatment from the definition of massage therapy in Section 6101. Massage therapy is currently ordered and accepted as part of normal treatment plans prescribed for patients by physicians and other healthcare providers covered under the Health Occupations article. This exclusionary language creates unnecessary barriers for access to care. In line with the removal of that restricted language in 6101, we are seeking to remove Section 6403 in its entirety. This section specifically restricts licensed massage therapists from receiving third-party reimbursement for medically necessary services. No other health occupations boards has this restrictive language. This update does not mandate that third parties must reimburse, rather that it allows for reimbursement for the services rendered under the scope of massage. Removal of Section 403 ensures all citizens have access to appropriate health care. We are licensed providers as defined by the statute. Additionally, the Universal Single Payer Bill, HB 25, Healthy Maryland is covered, massage is covered. For this reason, I ask for a favorable vote on this bill.
Hello again. Good afternoon, Madam Chair and the rest of the Finance Committee. Again, my name is Kirsten Bodnerchuk. I'm Chair of the Massage Therapy Board. I'm here today to speak in favor of Senate Bill 216. As a massage therapist for over 23 years, I can attest to the numerous health benefits of massage therapy. In my own clinic in Anne Arundel County, at least half of my clients are referrals from dentists and oral surgeons. Through consistent treatment, I'm able to offer relief for temporal mandibular joint dysfunction, which can be debilitating and affects daily life. I also receive referrals from OBs, physical therapists, even psychiatrists. Through these referrals, I treat many different populations, including but not limited to veterans, children, prenatal and postpartum clients, athletes, elderly, oncology patients, and more. The benefits my clients experience are numerous, but reality is that not every citizen has access to this care. I ask for you to favorably vote on this bill.
Thank you again, and good afternoon. I'm Sharon Oliver, and I am speaking not as the Executive Director for the Massage Therapy Board, but as an individual who had bilateral knee replacement and was the beneficiary of massage therapy treatment as part of my recovery process. When the physical therapist was unable to get my knee to the required angle, range of motion, I was referred to a massage therapist who was able to manipulate the soft tissue in my legs, which allowed me to obtain the range of motion that is necessary. This also helped me to relieve the level of pain that I experienced, eliminated the use of Oxycontin, which is an addictive drug, and really expanded the modalities that were available to me for treatment in my rehabilitation of my knees. For this reason, I am asking that the committee gives a favorable vote to this bill. Thank you.
Thank you. Are there any questions for the sponsor of this panel? Seeing none, thank you very much for your testimony. We will call forward Josh Howe, David Maiden, Sabrina Lopez. And I don't think Nova came in. All right. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I'm Josh Howe with Compass Advocacy here on behalf of the American Massage Therapy Association Maryland Chapter, or AMTA Maryland, here in strong support of Senate Bill 216. AMTA would like to thank the senator for bringing this bill, which addresses two main ideas, which I think he's summarized wonderfully. But first, the bill would remove the word treatment under the statute, outlining what massage therapy does not include. This is necessary because massage therapies can treat for illness, disease, and injury, including chronic pain relating to the back, neck, and shoulders, pain related to fibromyalgia, substance use disorder, and cancer management. The second portion of the bill removes language from the statute that insulates nonprofit health service providers, insurers, health maintenance organizations, and third-party administrators from providing reimbursement to licensed massage therapists for services rendered by that licensed massage therapist. Massage therapy is recognized as a valid treatment by the NIH, American College of Physicians, the Federation of State Medical Boards, the Department of Defense, the Veterans Health Administration. In a recent consumer survey of 50 million American adults, almost 20% have discussed massage therapy treatment with their doctors or healthcare providers. Additionally, there is significant data that shows that massage therapy can be used as non-opioid alternative to pain management, which could arguably reduce addiction and costs related to it. It is AMTA's position that licensed therapists should ideally be reimbursed for services rendered, especially if an individual maintains health insurance and the massage therapy was prescribed by a physician or licensed healthcare provider. AMTA believes that by removing the language under 6-403, page 2 of the bill, lines 11 through 16, it would bring Marylanders a step closer to getting massage therapy services reimbursed by their insurance. And for these reasons, we're asking for a favorable report.
Good afternoon, Madam Chair and committee members. My name is David Madden, and I am the president of the Maryland chapter for the American Massage Therapy Association. I am here today to speak in favor of Senate Bill 216. This bill repeals the fact that insurance plans, HMOs, and the like do not have to reimburse a licensed massage therapist or registered massage practitioner. Given the opportunity, many adults would have used or would use a complementary holistic health approach. In fact, there are even codes on the books for massage. However, the only ones who could really bill are certain healthcare practitioners, including chiropractic care or physical therapists. Many hear the word massage and think of the luxury relaxation aspect. However, there are many medical reasons that people would go, such as anatomical, carpal tunnel syndrome, fibromyalgia, back surgery. People go for depression and anxiety, or even migraines. Also, we have a major opioid epidemic on our hands, and massage can help reduce the number of opioids that are being used. Would you rather someone continuously be in pain or someone who seeks out these holistic approaches? By allowing massage therapists the opportunity to bill insurance carriers, it will greatly help our citizens of Maryland who might not have the luxury of spending money on receiving a massage. So in conclusion, I ask for a favorable report of SB 216. Thank you.
Good afternoon, Madam Chairwoman, Vice Chair, and committee members. Thank you again for letting us speak to you, Senate Bill 216. My name is Sabrina Lopez. I am a licensed massage therapist. I am the Government Relations Chair for the American Massage Therapy Association Maryland chapter. Just echoing what my colleagues have said, I won't repeat half of the benefits of massage, as I'm sure a lot of you know them as well. I thought I'd give you some interesting facts. There was a 2018 study that studied insurance companies and massage reimbursement. Of those, 23% of policies require massage to be limited to 15-minute treatment increments. 27% of those required a prescription from a physician for insurance to cover that. And 27% specifically excluded massage therapists as covered providers. We are moving away from that, where more insurance companies are now opening up and allowing massage therapists to be approved providers, but the restrictive language in our bill has given them another leg, so to speak, so that they can continue to deny insurance claims submitted by massage therapists. Currently, about 18% of massage therapists are being reimbursed by insurance. 8% of those are from health insurance. 6% of that is from auto insurance. 4% of that is from workers' compensation insurance, and 4% is other insurances. We would request that you give a favorable report for SB 216 to help the general public gain more access to massage therapy services here in the state of Maryland. Thank you.
Thank you very much. I see no questions from the committee. So thank you for your testimony and for hanging with the Finance Committee this afternoon. That concludes the hearing on Senate Bill 216. Colleagues, if you can stay put just for a moment, we're going to take a micro break and then we have to take a vote. We don't have to, we can just roll. Okay. We're going to take a quick vote on a bill. I'm going to ask David to explain what we're doing and why.
Normally, when bills are reassigned to other committees that are misassigned on the floor, we handle this informally and there's a letter of reassignment that's done and it's as a message on the floor, but sometimes we miss that 3-day window. And we missed the 3-day window on Senate Bill 626. This was a bill that would have required the members of the Health Services Cost Review Commission to be appointed with the advice and consent of the Senate. There was a similar bill that added that consent requirement to another body, and that went to executive nominations. So for this bill to get to the proper committee, you have to vote it for re-referral. So instead, it's going to show up on a committee report, and yeah, it'll show up on a committee report. You saw a bill last year that did this, last week that did the same thing. So you're just voting to re-refer to executive nominations.
I have a motion and a second on the favorable. I have a couple of objections, but all those in favor of re-referring the bill to the appropriate committee, raise your hand. Unanimous. Thank you. That concludes our work for the day. Thank you all very much. Happy Valentine's Day.